Hello.
You can go
Good
ahead.
evening to one and all. A very warm welcome and regards from JB Chemicals and Pharmaceuticals Limited. I, Dr. Jay Savai, on behalf of my entire team of JB Chemicals and Pharmaceuticals Limited, the makers of Rantac and Metrogyl, would like to welcome each one of you to this unique and fascinating learning workshop called Woundsights, Insights on Wound Management. We are a 46-year-old pharmaceutical company and are always inclined towards doing a lot of research and scientific engagements across the medical fraternity. And yet, once again, we are here with a very differential and a very innovative international scientific program for all the postgraduate students across all India Medical College, as well as young and practicing clinicians watching us live from different parts of the country. This is an academic program conceptualized in association with an internationally acclaimed body, DFoot International, along with the Association of Surgeons of India and Mumbai Surgical Society. As we all know, India is the diabetic capital of the world, and the continuum of diabetes is from macro to microvascular disease, and one such complication is diabetic foot ulcer. And today we are going to learn and understand a lot about diabetic wounds through various sessions and lectures. And to tell you more about the knowledge gaps, innovation, evaluation, prediction markers, clinical needs, we have with us a very senior and a very passionate researcher and academician. And it's my pleasure and honor to introduce to all of you today's program director, Dr. Milind Rukesar. Dr. Milind Rukesar is an HOD of surgery unit at Kurla Baba Institute in Mumbai. He is a practicing consultant surgeon with a rich experience of more than almost 2 decades. He is also an ex-associate professor of general surgery at JJ Hospital, also an adjunct external faculty at New York College of Pediatric Medicine. He has got numerous publications in his name, which are being published both in national as well as international journals. He is also a famous faculty which has been invited at several national as well as international conference, and the feather in his cap, he has also taught many graduate as well as postgraduate students for almost more than 1 decade. I think it's a pleasure to have you, sir, with us. And now, without much wasting time, I would like to hand over this platform to Dr. Milind Rukesar. Over to you, sir. Thank you so much.
So, Dr. Jay, I am overwhelmed with the introduction that you have given, but thank you for those kind words. As the program director and regional advisor to Diabetic Foot International, I welcome all of you delegates, the international speakers, President of DFoot International, Dr. Zulfikar Ali Abbas from Tanzania, Dr. Vijay Vishwanathan sir, who is immediate past president from Chennai, India in DFoot International, and Dr. Harikrishnan Nair, president-elect from Malaysia. The national speakers, Dr. Tushar Rege, Dr. Manisha Jadaung, Dr. Madhu Periasamy, Dr. Amit Burande, and moderator, Dr. Amit Nagate. I also welcome national and international delegates and especially the postgraduate students on board for this program. Firstly, I thank the DFoot International Board who have given permission to initiate this one of its kind first endeavor to contact medical colleges all over India primarily and postgraduate students in Malaysia, Africa, and other parts of the world if they are logging in. We have given this project and the name is Catch Them Young, where we not only want to catch the diabetic foot disease at a young initial stage and prevent amputation, but also reach out to young postgraduate students to create awareness about this disease at student level, which we thought would be helpful in limb salvage and amputation prevention in diabetic foot in the whole world, and more so ever in developing countries like Africa, Southeast Asia. I also welcome other physicians and surgeons who are interested in diabetic foot who have logged in. This concept of Catch Them we had discussed in a meeting pre-COVID in Spain, Madrid. And I'm glad we are doing this program today as the first in the series. I'm thankful to the Mumbai Surgical Society Executive Committee who helped in accreditation of this program. I welcome Dr. Abhay Dalvi sir, past president of Association of Surgeons of India, who is today present as an MMC observer. Thank you, sir. I am very thankful to the organizers who gave this great online platform to initiate this knowledge sharing and awareness program. With that, I would like to not waste much time because all our international speakers are very busy. I would like to introduce the first speaker, who is none other than Dr. Zulfikar Ali G. Abbas, who is the present president of DFoot International. He is awarded FRCP honors from Royal College of Physicians and Surgeons of Glasgow and Royal College of Physicians of London, chair of Pan-African Diabetic Foot Study Group. He is an executive board of IWGDF for International Consensus on the Diabetic Foot. He is a founder member to Start Step by Step Foot project started in 2003 in Tanzania. He is a member of editorial boards of several international peer-reviewed journals. And he received the Carol Becker Award for Diabetic Foot for Health and IWGDF Award in 2019 and Life Achievement Award of World Union of Wound Healing Societies in 2022. And sir is going to talk about diabetic foot, a global epidemic. Sir, please go ahead.
Can you see my slides?
Yes.
Okay. Thank you very much, Mr. Chairman Millen, for kind words. Thank you. Good morning, good afternoon, or good evening, wherever you are. Today's task is I'm going to talk on the global diabetic foot perspective. Before I start my talk, I would like to thank all the organizers and all the people who have worked behind the curtains, and special thanks to the program director and moderator, Dr. Milan Durok. Thank you very much, and it's really honor and nice to be here as a president of DFoot International to invite me to give this talk. Thank you very much. As we are aware that Africa and Asia are two the largest continent in the world, and which caters about 76% of our population, and they cater about rest of the world, that's North America, South America, Antarctica, Europe, and Australia, caters about, the population is 24%. So huge number of diabetes come from our part of the world. 80% of diabetes are from this region. So that means we are actually the global problem. We have the main problem, and we still have double burden. We haven't finished with communicable, and we are adopting non-communicable disease. Look at the diabetes prevalence globally, and we can see that at the moment, like you heard Melvin said, that Southeast Asia, India is leading in diabetes, but in next 20 years, it's going to be Africa which is going to lead, and it is going to be the highest increase of 134% increase in diabetes, followed by Middle East, and then Southeast Asia and South and Central America. So we already have already a double burden, and the resources, human or finance, are still lacking. With increase in prevalence of diabetes globally, obviously everything is going to increase. This is a flow where you can see just 20 years ago, 2000, we were 7.1 million. After 20 years, we became 19 million. And in next 20 years, we are expected to lead the world, which is not nice thing to lead in this thing, 134%. With increasing diabetes, obviously the complications are also going to increase. And what we are going to talk today is on diabetic foot, which is a more than 60% of non-traumatic lower limb amputations which occurs in diabetes patients. So diabetes-related food complications. Worldwide, there is a parallel increase in complications, and one of the dreadful complications is diabetic foot, which is a major public global problems. And wherever you are, there are always the cases of diabetic foot, and consequently, mainly it is because of neuropathy or arterial disease. In our setup, low middle income countries, we have an infectious etiology, and obviously the cost is not sustainable to the patient family or in large to the nation. Gangrene and infections are the main cause of amputations. True prevalence in our part of the world will never be known. It's always underestimated because 90% of population in rural area, which we don't know, published report says that delay presentation is the main cause of amputations, and most of the patients who reach to the surgeons die even before they need any intervention. So in 2005, it was a diabetic foot year where we had estimated, and I was part of the committee, that every 30 seconds there is an amputation occurring, and that means 2 in a minute. But in 2017, we re-estimated and predicted that now it is 20 seconds. That means all these conference, seminars, hands-on experience, and all these workshops doing it, we actually have grown from 2 to 3 amputation in a minute. So we have gone from bad to worse, and we need more to be done. This is a complex interplay of various factors, which I'm going to touch a little bit and go along with this. These all are it was Professor Andrew Bolton and myself, we published this paper in looking at the African continent and the review of diabetic foot in the last 60 years. And it is more or less similar what you see all over the world. So most of the references are going to come from this paper. Descriptive etiology. If you look at the peripheral neuropathy, where were we since in 1994, there was a secular increase from 25 to 82% and remains the major underlying risk factor of an ulcers, necrosis, gangrene, and loss of limb or even the patient. Look at in West, the prevalence of peripheral neuropathy ranges where you are between 5 to 80%, and it is similar wherever you are, whether you are in low or middle income countries. We are almost at the par with the Western world in this peripheral neuropathy. These are major underlying risk factors for ulcers, infections, and amputations. These are some just picked up from the Africa region. You can see all of them are very high levels of peripheral neuropathy, and it's a similar wherever you are in the world, the same rates, which you can see. These are past 20 years, and you can see whether you were in 2002 or in 2023, it's the same thing, double digit and high, similar, equivalent to the Western world. Peripheral arterial disease. We characterize the epidemiology of peripheral arterial disease. It's a direct established link with urbanization, which is exactly what we see in the Western world. Now we also see in low and middle income countries, and we have established the prevalence rate in one of our studies. Several studies have been done, but one of the recent one is 21%, and the data almost similar across the continental. You can compare them with Western world. So PAD is also increased in low and middle income countries, and as I mentioned, is associated and increasing with urbanization. So we are developing with the cost of our health, and the rates across Africa and all over the world in low and middle income countries, as well as in high income, it was already there, are almost increasing. Look at the Africa. I can show you as an example. All of them are double digit and similar what you see everywhere globally. So they are all increasing. This was last 2020, and if you see past 20 years, we've been going up. But just look at it, when we were in 1990 and below, it was a single digit or none. So it was like a non-existing. But now we are almost in comparison similar to what is happening in the Western world, whether you are in Southeast Asia or you are in Africa or you are in Western world. This was one of the study which was done about 20 years ago, where it was in Germany, where Caucasian patients were taken, the African patient, myself in Tanzania, and Dr. Vijay Vishwanath, which is part of this seminar here from India. And you can see wherever you are in the world, peripheral neuropathy was similar, around 80%. But that in 20 years back, arterial disease was more in Germany compared to Tanzania and India. This is now not true. Now we are almost similar at the par with Western world. Charcot neuropathy, which is one of the topic today, is also increasing. We never used to see Charcot 20, 25 years ago. Our patient used to die because of septicemia, but now we are almost becoming at the par with our colleagues from Western world. One of the study done in Tanzania, 18%, and similar thing coming up from other African countries and in Southeast Asia. Diabetic foot ulcers, a study done in Tanzania, 15% of the admitted patients with diabetic foot, and the similar data are coming from the Western world up till 25%. 80% of these patients had no previous history of ulcers. Studies across Africa show similar wherever you are in the world, and you can see wherever in Africa, all of them are in double digit. Diabetic foot ulcers admitted in the wards. Time is tissue in diabetic foot, and these are the feet which have been delayed, and it's very common. I wanted to put this thing because it's very much related to us, where 80% of the diabetic patients are there. These are the patients where there was no time in tissue, and these are the patients when by the time reached to the surgeons, it's really difficult to save the foot, even the life of the patient. So this is a typical sequential time with the patients usually starts at home treatment where they have already lost 1 week, then they go to the herbal or a fat healer. It's very common in Africa and Asia. Then they're here also, they've already lost about 1 or 2 weeks. Then they go to the primary health center where the facilities of diabetic foot or is not there. Then they visit to the district and regional. By the time they come to the referral hospital, it's again very difficult to save the life, even forget about the foot. So there, the patient, when it comes, it's too late. That's where the fast-track pathway had come. This you can see high rates of mortality and amputations, somewhere similar wherever you are in Africa. Now, prevention. A sustainable infrastructure is needed to reduce amputation in the world, and especially in low and middle income countries. Most foot problems are preventable through early identification and prompt treatment by skilled healthcare professionals. And as I always say, and would say it again today, that education is the only powerful tool we have, especially in low and middle income countries, which is free of charge for the patients and effective if implemented properly. One of these programs was step-by-step foot project, which was started 20 years ago. And this project showed that ulceration, infections, and amputations are potentially preventable if the education is spread. All health workers who to target for prevention for foot care in reducing amputations, all health workers at the primary setting, because they are the people, they are the first people at the catchment of the major population in our part of the area, should be able to conduct at least simple neurological screening and vascular screening to identify people, patients with diabetes at high risk. Now, coming to the Deep Foot International, which is an organization consists of people filled in diabetes related foot disease. And these are people across 7 regions, and the aim is to avoid amputation globally. These are all projects which we have been planning next 2 years, but what we are related here is to trend the foot trenocosis and World Diabetes Awareness. Now, the trend of foot trenocosis was started first initially step by step, and then went to the trend food, and then train the healthcare professionals. We have about 5 this in 2 years, and this is because of prevention, dissemination of education in all the regions. Basic educations, which people should be targeted? That's the always question being asked for foot care education. So people in a ward, in a clinic, or where when we are coming from the low and middle income countries, especially in Asia and Africa, there's a huge, we can have a population of 100 patients seeing, but we have to prepare a system somewhere where we can catch this thing. So this is a evidence-based strategical risk, service risk category system, where if you have a grade 0, these are the people only need a general information where there is no neuropathy or arterial disease. Grade 1, these are the people who needs to be checked every 6 months and the knowledge frequency should increase every 6 months. Where there is a neuropathy or arterial disease, but there is no previous amputation or ulcers. Grade 2, where these are the people, they need more education every 3 months, and these are the patients who have a peripheral arterial disease, peripheral neuropathy, and deformity. And the last one is grade 3, which is highly risk patient who needs a intensive foot education every 1 in 3 months, who had a history of previous amputation on ulcers. So this is a graph starting from general information, going to intensive foot education for a high-risk foot to avoid an ulcer. Foot care education, if we have low risk, then simple advice, no lifetime annual assessment is okay. But if they come to the high risk, then intensive education, practical demonstration, significant behavior changes is needed here, and obviously focus on prevention, so that education comes here to prevent further ulcers. This is just a memory retention, make use of many sense, whether we are a health professional or at the level of the patients. The people retain 10% of what they have read, so brochures and leaflets, and 90% is not gained. 20% if they only hear, 30% if they see, 50% is retained when they see and hear, 70% what they say, but 90% what they say and do, practical demonstration. So engage the patients in education process, let them see, feel, and touch, and make sure when you use the education tool, it is used well prepared locally. My question, where do we go from here? In summary, many reasons for poor food care is being targeted at low middle income countries and have been discussed. An increase in high technology, rocket or molecular genetic science will not change the practice of diabetes food in low and middle income countries. If we have to ask what will change the practice in diabetes related food complications in our part of the world in next 25 years, then reply to this question is not high technology, but rather dissemination of knowledge at where the 90% of the patients are there. And the two distinct areas this has an impact as seen in the work done, a powerful tool for prevention and control of complications of in the low middle income countries, and obviously to empower healthcare professionals. This is one of the program, and that's thanks to our program director moderator. This is a dissemination of knowledge to healthcare workers, and obviously the end result would be the patients. And we can see it's a very nicely set up. So the take-home message on prevention of diabetes-related food complications is patient limb amputations can be reduced by more than 50% through only these 5 things. So if a person has not been listening to me, this is the last try. You can take regular foot examination, identification of high-risk feet, and I've already mentioned appropriate footwear, treatment of non-ulcerative pathologies, which is mostly neglected when a patient comes with a callus cone or a fungal infection, and obviously education, which is the most important thing, should be given to the healthcare workers, patients, relatives, and wider space. So in conclusions, diabetes-related food problems are common all over the globe, and the major economic consequences society, patients with diabetes and their family. The most important tool we have in our part of the world is education, which should be part of all the programs on diabetes care, simple, repetitive, and must be targeted to the level of the medical students, which we heard from Dr. Malin, what he said, and healthcare professionals, patients, relatives, and friends. Key recommendation is to encourage healthcare professionals to remove patients' shoes and socks and examine the feet. Unfortunately, this simple advice is ignored in many parts of the countries, due to the many parts of the world, due to the lack of resources, human or financial, do not stop us from a simple rule to maintain tight control of blood glucose or diabetic food care in low middle income countries. This is my last slide, and I would say that our patients with high-risk feet are walking step by step towards the road to amputation, and by implementing any education project in a fast-track pathway approach, we wish to take them around step by step to the road of safety. Thank you very much. Milan, you are mute. We can't hear you.
Sir, thank you for such a simple overview on this global epidemic of diabetic foot. I thank you for that. I have few questions for you. As a president of DFoot International, what are your plans for underdeveloped countries for prevention of diabetic foot amputations? Do we require more podiatricologists in our countries, in developing nations?
I will repeat here that education is the only powerful tool we have, especially in low and middle income countries, which is free of charge for patients and effective if implemented properly. In summary, many reasons for poor care food have been discussed. This high technology will not help us. What we will need is dissemination of education. And I already mentioned that that is the only thing which will change in next 25 years and the practice of diabetes related food complications. And so reply to this question is not high technology, but knowledge, dissemination to knowledge and to empower the healthcare professionals.
Thank you, sir.
Well, DFoot International has already, I already showed you, has already done several projects, and our main aim is to disseminate more and more education. And that's why I always promote, and one of them is this, that we need more education to prevent amputation. Regarding your second question of podiatry, before I comment to this on it, let me say that podiatry at the moment is not even existing in most of the low and middle income countries. Podiatry is not even considered in most of the, I only would say only 2 countries so far have been accepted as by the medical council in most of the low and middle income countries. In Africa, apart from South Africa, and recently, only a few months back, Kenya was accepted by medical councils. So at the moment, who are working, our nurses are the backbone for us in low and middle income countries, and they are the podiatrists and the mini surgeons. The question is, I would say, yes, we need to work on this for having a college in developing countries. We do need them.
So I think, sir, we'll move on because of the time constraints. Our next speaker is who doesn't require any recognition is Dr. Vijay Vishwanathan, who is the Chief Physician of MV Diabetes Center in Chennai and Professor M. Vishwanathan Diabetic Research Center, Royapuram, Chennai. He's the incoming National President of RSSDI, which is the largest diabetic organization, and he is the past president of DFoot International. Sir is going to talk about diabetic foot disease Indian perspective. Sir, we would like to hear from you.
Thank you, Milind. I think it's a wonderful idea which you created, which you formulated. There's Catch Them Young, and I think it's we would like to thank you for applying this knowledge of Catch Them Young in India to start with. I'm very sure that DFoot International, with the incoming president Hari Krishna and the present president Abbas, will take it up to other countries. Your idea. So I think Catch Them Young is a fantastic concept, and I think DFoot International is honored to associate with you and with this concept. So with that introduction, let me share the screen. I hope it'll work. So my talk is only for 10 minutes, and I'm sure Abbas will leave now because of professional commitment. So I think the physician has got an important role to play. Let me search for the laser pointer. So the normal foot and high risk foot. You heard the president of the DFoot International talking about high risk feet. So we have people with diabetes who just walk into our clinic. Not all of them have a high risk feet. Not all of them have these complications. Some of them have normal foot. So you need not spend all your resources in examining every time they come their feet and so on. So high risk feet is characterized, I'll tell you in the next 9 minutes of my talk, is characterized by loss of sensation, insensate feet, or vascular disease too, or if they have a past history of an ulceration. or amputation. So these are the qualification of high-risk feet. So such people have to be examined according to the IWGDF every 3 months. Now, our aim as diabetologists, physicians is to prevent the stage of ulceration, infection, necrotic feet, and unsalvageable feet. So this is a simple algorithm given by our colleagues from King's College, Mike Edmonds and Ali Foster, who created this simple algorithm of stage 1, stage 2, stage 3. So my talk in the next 9 minutes is going to be who's going to examine. So you have, say, 50 to 100 patients coming in every day to your clinic. I'm talking about a physician's clinic. Now you can train anybody up. Today, nurses quite quite hesitant to examine the foot because they want to give intravenous injections and they want to put in catheters here, catheters there, and so on. The doctors are not tuned towards examining the feet. So who's going to do it? The podiatrist, as you heard from Dr. Abbas, the president, does not exist in most of the countries. So who's going to do? Any suitable trained member of the primary healthcare team. There are clinics in India where even dietitians do it. Dietitians are trained to do foot examination. And I'm going to show you how simple it is in the next 8 minutes. So first is we test the large fiber of the large nerve fiber in the feet by examining with the monofilament or with the vibration 128 Hertz tuning fork. We examine 3 areas, 1, 2, and this third one is not shown. Or is it shown? No, it's not shown. So you have 3 areas here and 3 areas here. And one is a sham area, sham. You don't actually examine the foot there. But if you can't feel in 2 out of 3 areas in one foot, he's got insensate feet. So this is for testing the large nerve fiber. The Ipswich test is a test which is used to just touch the feet. It was first described by Jerry Raymond in Ipswich in UK. Spelling's wrong, I'm sorry. There's no T there. You just touch the foot and the first and the third and the fifth toes. And if the person with diabetes cannot feel the touch, he's got. So this is a very simple test for patients to test at home every year. So this is a simple test. Now temperature, Dan Ziegler showed that the first sensation from Dusseldorf, he showed that the first sensation to be lost in the foot is temperature. And in India, we have 2 companies, the Diabetic Foot Care India of Ilango and Cody's of somebody in Chennai, both are in Chennai. And both these companies have made the examination for small nerve fiber quite easy. Otherwise, you have to depend on a temperature, a test tube with hot water and cold water, which is quite cumbersome. So you have the testing for small fiber, and that is the first temperature to be lost. And people who have painful diabetic neuropathy have have involvement of the small nerve fiber. Don't forget that you heard from Dr. Abbas, the president, that about 30% have peripheral arterial disease. When we did the study some years ago, we found only 12%, 13%. But here we have the handheld Doppler, which is costing around, in India, it costs about 30,000 rupees. And you can examine with your hands the posterior and dorsal pulse. You can also examine with the handheld Doppler. You have a sophisticated device called in India, it is available. It's from Germany. And we have the 1-minute test for checking the ankle brachial index. So the circulation to the leg, the foot, can be examined either by a handheld Doppler or this costs about 1 lakh Indian rupees. So you can examine with the 1 minute. It takes 1 minute to check the ankle brachial index. Now, Andrew Bolton and Carolyn Abbott came up with this nice algorithm, which is very simple and which can be done even in rural Bihar, in a small village, or rural Kenya or Tanzania, where we look at the large fiber, small fiber, and we look at the large fiber again by using a simple tuning fork, simple, I'm sorry, a knee hammer. So you examine for the ankle jerk, and examination of the ankle jerk is done by keeping the foot parallelly in like this, and you tap here on the ankle reflex here. I'm sorry. Uh, and if you can't elicit an ankle reflex, you get 2 points, 2 + 2. And all the others, if you can't elicit or the person cannot feel temperature, vibration, pinprick, they get 1 point. And what Carolyn Abbott and Andrew Bolton showed in 2002 was that if you have a neuropathy disability score of more than 6, then your chances of ulceration is more. So it's very simple. This was uh, the study which Carolyn Abbott and Andrew Bolton showed several years ago, and it's very valid. And all that you need is is a 128 hertz tuning fork, something to test the temperature like what I showed you, something to test the pinprick, and you need the knee hammer, the long knee hammer, to examine the ankle jerk. Don't forget that people with neuropathy and insensate feet might have uh, deformities in the feet. So it's very important to examine for deformities in the feet. Now, people, it's very important offloading the insensate feet. It's very important that you give them footwear which is acceptable. These are people with diabetes who have loss of sensation. That's it. And you can't give them footwear which they cannot wear to office. So we have developed these footwear uh, along with the Central Footwear Technical Institute in Chennai, and also the CLRI, and it's available in Amazon. Now there are people who have deformities in the feet who cannot be given these footwear. So we have a lecture coming on Charcot foot. So people with Charcot foot should be given specialized footwear, what is called customized insole. So we have our technicians who make these footwear according to the need of each patient. And it goes without saying that modern technology does help uh, in some cases. You do the debridement, and since this is a wound conference, I need to talk about this. This person came during the COVID times with a lot of maggots in it, dirty maggots, not the clean maggots. And the surgeon does a debridement. And after 2 to 3 weeks of wound care, he puts in a skin graft. So it's very simple. So in the last 10 to 12 minutes, I was talking to you on how we can detect insensate feet and peripheral artery disease, which are two important factors, and deformities. And one is the question, which is a past history of ulceration or amputation. So by these four parameters, we can actually make a diagnosis of high risk feet. And this is the only way, as Abbas said, by education of the people with high risk feet. You can't educate everybody. We have 100 million people with diabetes in India. So we can't educate everybody. So we can educate people who have a high risk feet to take care of the feet. And high risk feet is very easy to find out by the methods which I told you. And you can prevent an amputation. So I'd like to thank Milind Roke for this invitation. And I would like to compliment Milind Roke for taking up this fantastic project of Castan Young. And I would like to thank Abbas and the incoming president, Dr. Hari Krishnan Nair from Malaysia, Kuala Lumpur, who is going to do the wound conference next in 2025. and he's the next speaker. Thank you very much, Milan.
Sir,
Congratulations
thank
once
you.
again.
Thank you, Dr. Vijay Vishwanathan, sir, for talking so elegantly as always. As a diabetologist, sir, a question to you is, with so much of work in diabetic fit you have done, what is the thing that you think is most needed in India to achieve amputation prevention? And the
So I
related,
told you I once already answered that question, Milan.
Hmm.
As Dr. Abbas, our president, said, education, education, education. It's not technology. It's not high-end technology which is needed. All that we need is to examine the foot. The patient has to examine the foot. We have to examine the foot. We have to spend time with the patient and educate, educate, educate. So that's the only way. Thank you.
So footwear is not sanctioned in Mediclaim in Asia. How this policy can be changed? Any
So everyone should understand that offloading is an integral part of healing and prevention and healing. Prevention and healing, offloading is very important. So it is only but natural that, and patients don't like to spend money on footwear, on offloading. So it goes without saying that it should be reimbursed. So if you don't reimburse an integral part uh, of prevention and treatment, then you are not you are ready to pay for revascularization, but not ready to pay for offloading, which is wrong, absolutely wrong. Thank you very much.
Yes, sir. Thank you. Thank you, sir. So we go forward with welcoming the incoming D-Foot president, D-Foot International president, to our conference today. President-elect of D-Foot International, Dr. Hari Krishna Nair, Professor Hari Krishna Nair. He's the president of the Malaysian Society of Wound Care Professions and chairman of the Commonwealth Wound Care Resource Alliance and chairman of the Asian Wound Council. He's vice chairman of the National Technical Committee on Wound Care at the Ministry of Health Malaysia and is the editor-in-chief of the Wound Asia Journal, Journal of Wound Care and Malaysian Journal of Medical Research. And he is going to talk to us about advances in diabetic foot management. Dr. Hari, can you please enlighten us?
Thank you, Milan. It's a pleasure to be here. Can you hear me clearly?
Yes.
Yeah, we can.
Okay, thanks. Just screen share. Firstly, I would like to take the opportunity to thank you for inviting me. And it's a pleasure actually to be here, especially, I mean, since Abbas and all of us have always talked about education as the main brunt of our management. And you can see both basically in the presentations of Abbas and also Dr. Vijay Viswanathan, basically, D-Foot is all about education because that's the most important thing. And I think one of the things that we require is to know what is out there for our diabetic foot patients. And the same thing as, Africa and also South Asia and also the Asia Pacific region or the Western Pacific region, diabetes is a big problem. And this actually is a thing that we have to manage. Now, I'll be touching a bit about the advances in diabetic foot management. This actually is newer things that are coming. One of these topics I like basically is something additional to know that, we always try to reach for the stars. I think Winston Churchill once says that, when you actually have a destination in mind, go for it. Don't stop for barking dogs. So same concept basically, you see, so you need to, have, these are the things that are actually there. This is standard of care. And our patients should get the same standards, whether in India, Malaysia, Tanzania, or even basically in the US or UK. That is, patient-centric care, which is standardized, individualized, and they get the best of care. And you can see in both presentations before by the past president and the present president of D4 International, they have showed you how they are actually managing these patients with the best of their knowledge and best of all the resources that they have. Now, this is a disclaimer. I'm actually from the Kuala Lumpur Hospital, which is a hospital with about 2,500 beds. So we were running a diabetic foot clinic for more than 15 years. And then for the past 11 years, it expanded to a wound clinic. And 70% of our patients are still diabetic patients. So I will cover basically about copper dressings, electroceuticals, and also some biotherapy in this 10-minute presentation. Now, the first thing is whenever you look at a wound, you want to actually assess the patient itself. That means a general assessment. Don't just assess the whole in the patient, but the whole patient itself. So time is something which was actually alluded to in the year 2003 and revisited in 2017. And after that, they have come up with a new assessment tool, which is known as time clinical decision support tool. Now, time T is for tissue, I is for infection or inflammation, M for moisture imbalance, E for epidermal margin. And then you have got the surrounding skin or the peri-wound skin management. And then you have got the clinical decision support tool, which talks about A, B, C, D, E. A is to assess the patient's well-being and also looking at the wound. B basically is bringing in a multi-team approach, as what was done by Mike Edmonds. He'll be talking about a multi-team approach for many years, for about more than 40 years. And then you basically have to control the underlying causes. In this case, basically for diabetic foot, it basically is to control the glycemia. Hyperglycemia is very important. That's why you need a proper team. You need the diabetologists, the endocrinologists, and all that to work together. You need the diabetic nurse educators and all that. And then the thing is, next you move to decide an appropriate treatment. That means treatment not only basically looking at the wound itself or a diabetic foot ulcer, which is, and you can see even about has mentioned that, every 20 seconds amputated. And that's in 2011. There are even what they call as latest studies, which actually show that it's up to 18 seconds. So it's actually worsening. All right. And it's actually a purely massive pandemic. And more people are actually getting diabetic foot problems. Like, it takes about 1.2 seconds for a patient to actually develop a complication. And the thing is, if you look at the number of diabetics who are dying, every 7 seconds, a diabetic patient is dying. So there are a lot of studies which shows that it's actually a very dangerous problem. And at the same time, number E is actually to evaluate the whole thing. That means whatever you've done, you have to monitor key performance indicators, and also other indicators to see whether the wound is actually becoming closed or whether there are any deformities. And then there's another concept of a biomechanically viable foot. That means whether the patient can actually be put into some form of orthosis or prosthesis and able to actually ambulate. That's very important. And you can even use other kinds of assessment, whether it's a triangular wound assessment or MOIS or anything, depending on the place itself. So now when we go to what you call this copper dressings, we talk about wound care to wound cure. Now this actually is very new. We find that, actually it's new as a dressing. But if basically in India, copper has been used. Even my forefathers have used copper. I've used copper in terms of pots and glasses and all that. And even, in terms of containers and all that. And they keep the food, what do you call this? Well, and it was usually used as an antimicrobial. They used to paint with green paints and all that. And they used to use copper oxide and all that. So it's an antimicrobial. So you find that, the list of bacteria here can actually be killed by copper itself. Now, I'm not touching about silver. There's enough silver products in the world, basically. So in the new advances, we're looking at copper. We have copper solutions now. We have copper dressings and all that. And you find that it actually kills in a multi-site, non-specific kill mechanism. That means very rare for you to get any resistance. And you find that, these dressings are actually on an external non-woven or non-binding fabric, and you can actually apply onto wounds to actually kill off all these germs. And if you look at the wound infection continuum, whereby there is local infection or spreading infection or systemic infection, you find that these copper dressings can be used as an antimicrobial. Now, one thing is, in terms of cytotoxicity and also irritation and all that, it's actually quite well used, and there's no problems in terms of allergic or even irritant problems. And it has got a more than 4 log reduction. All right. It can be used in a variety of cases. So here we'll cover basically on diabetic foot ulcers, especially the infected ones. And you can see in an infected wound like this, basically a septic hand, basically in this case, whereby, the reason is when we set up the Asia Pacific Association of Diabetic Limb Problems, we put it as diabetic limb because you can even get in the hand. So you find that even in this patient, basically with the copper dressings and all that, you can see the improvement. Okay, the wounds actually get better, a proper wound bed preparation with very good granulation tissue. This is another patient, basically at the foot, and you can see, heavily infected, and it clears the infection itself within 7 days of copper dressings. So the other aspect of copper is also as it helps in terms of angiogenesis, that means wound healing itself. Now, copper is one of the 11 trace elements. So people have taken Centrum and other types of copper supplements and all that, and you're allowed basically 1 milligram of copper per day. And the thing is, usually when you have copper dressings, the bioavailability is very minimal, so it doesn't cause any problem like what you call as hyperchromatosis or even Wilson's disease or any of these. And you can see in this, even non-infected patients, with diabetic neuropathy, first raise, osteomyelitis, that post-raise amputation, you can see the difference is it clears up the infection itself. All right. So that means it can be even used for a non-infected wound. So it's not only as an antimicrobial. Now, this is a particular patient where we actually use negative pressure wound therapy, and we applied copper dressings also. And you can see basically, within 21 weeks, the wound is completely closed. So there, copper was actually used as a, what do you call that, as a wound interface. Okay, so quite a number of studies basically done by Gary Borkow and team and all these things, and it's actually coming up. So it's something very new, and it's coming out in most places. Now, this picture I actually put up, basically me and David Armstrong basically chairing a session during the International Symposium on Diabetic Foot, basically when the IWGDF documents were launched. And I think this goes well into Milan's topic, talking about podiatry in Asia Pacific and all these things. So he just came down to Singapore just about, he's there now currently. And he's one of the main authors of diabetic foot journals, basically, in the world. I think #1 at the moment. Now, the next aspect is looking at electroceutical dressings. Now, what happens is in this particular dressing itself, you can see basically these brown circles here are actually flat zinc oxide batteries. They actually come out with a current, and it's impregnated with zinc oxide and also, with silver also, silver zirconium. So both of it actually, you find that it's actually antimicrobial. And these zinc oxide batteries actually help to come out with a electrical current, which can basically lyse the cells of the bacteria. So you find that, problems are now we're having a lot of chronic wounds. 78% of them, or 78.2% of most of the chronic wounds have got biofilm. This is actually by Matt Malone and group in Australia. And then you can find that, that silver ions are nowadays, you find that there's a problem whereby you can actually have cytotoxicity. And clinicians are actually looking for better alternatives. So this, with the zinc oxide batteries and all that, will actually have an electroceutical way of managing it. And you find that it's not only just purely silver alone. Now, if you look at silver ion release here, basically, some of the silvers can go up to about 87%. That's quite high. And you just need, basically, this is the only level you need for bactericidal effect itself. So you don't need so much of silver because it can cause toxicity, especially to the extracellular matrix and the fibroblast itself. And you find that, patients also have a lot of biofilm, and that needs to be removed. One of the things is basically penetration and removal and preventing the recurrence of these biofilms. So when you actually use what you call these electroceutical dressings, which are quite new, basically coming from the US, they actually, support your advanced wound healing and disrupt and prevent all this biofilm formation. Okay, so these microcell batteries, which are actually flat over the area, together with the conductive medium. So we use the energel basically, and then we apply it. So at least if the patient doesn't have enough, if there isn't enough exudates, we can actually apply the gel, and this generates electricity. And you can find basically that, even in a wounded skin, there's a change in the electrical potential. So when you actually apply these things, they actually support the natural healing process itself. Now, this is one particular area where you put standard of care and we use electroceutical. And you find there was a 53% faster healing, okay, at 1 week versus your standard of care itself. And there was 72% of epithelialization in these patients. This shows you the Pseudomonas aeruginosa biofilm and also the Acinetobacter baumannii biofilm. And both of them, once you use these electroceuticals, you can see completely absence of the biofilm, right? So it's quite clear in terms of biofilm eradication. And in terms of standard of care, it actually significantly decreases the biofilm severity in burn patients, and also it is much more superior to just pure silver alone. So there's quite a number of studies basically. And you can see one of the main things is to remove these biofilms. So it's about 29 peer-reviewed publications, and we also published a paper recently, and studies are ongoing about with this product. So far in Asia Pacific, it's actually the first one being used in Malaysia for some time, just before COVID itself. So this is your procellular antimicrobial wound dressing. You can see basically in these kinds of patients, this is in Costa Rica, just to show the improvement in these patients, all right? And in terms of total knee arthroplasty, all right, you can see basically in terms of scarring also, there's an improvement. And this is a traumatic scalp injury, all right, an improvement in this. Road rash injuries, basically, patients who actually were having diabetes and all that, very prone to infection, so you can clear that. And venous insufficiency, same thing also. Okay, so we've been doing a lot of work on diabetic foot. This is a snake bite. And this is, I put this up because it's quite common, basically. I mean, in India, some parts of India, you still have snake bite victims and all that. And together with this, we can actually apply negative pressure wound therapy. And that actually helps. And you can see 7 days post NPWT and your electrosurgical, there's an improvement. All right. And following that, basically, skin grafts are applied. Okay. Diabetic foot ulcers, same concept, basically 21% reduction and also 81% reduction by day 24. And you only need 50% reduction within 1 month. Skin tears, basically another big problem nowadays, especially the geriatric age group. And this also helps to actually make sure that it gets back to normal. And it's about 1.5 months, basically. You can see the improvement. Pseudomonas infection is one more thing that it can be covered, as even with what we call this Staph aureus. You can see an infected liquid nitrogen burn case also, right? So these are actually helping in terms of removing the infection itself. Okay. And in 1 year follow-up, you can see no adverse reactions, no complications, all that. And the scar appearance here also, basically, when you find the dressing is in contact with the skin itself, you can see the difference much better, basically, at these 2 sections here. So the future of infection control and wound healing is electric. That's what the new dictum is, basically. So you find that that's something you can actually use. And we also have other types of modalities such as microcurrent and all that, which is also using the electrical meter modality. Okay, so when all is that, basically, once you have done that and cleared up with all this, you can actually fly down to Maldives. This is a picture of Maldives where we work with the Maldivian Association of Surgeons. So I used to go down there once a year for 4 years continuously to set up their wound care teams in Male, in the Indira Gandhi Memorial Hospital, and also in Hanimadu, Addu, and also Kuldu Fiji. So this actually is the SARC region itself. So I mean, now it's something that which is good, and they have a lot of diabetic foot cases. Now the other thing is, one of my masters was basically from Cardiff, where I looked at what we call this leech therapy in lower leg wounds, especially diabetic foot ulcers. So one of the things is we actually find that, the leech itself is something that can be used. And Hirudo medicinalis is a leech that is used internationally. In Malaysia, we actually use Hirunaria medicinalis. And Hirunaria melensis is actually the leech that is actually a sterile leech that we have actually sterilized in our Institute of Medical Research. Now, it's used a lot in reconstruction and also in plastic surgery. There's a book by Costa from Israel, and he talked about venous congestion of free flaps and all that. So in that case, when a distal congestion, you actually can have leeches. You can use that for these cases. And in terms of this textbook, basically in the International Biotherapy Society, which I'm also a member of the board, we actually have what we call this published papers using these leeches. Now, the good thing about this is basically the entomologist and myself basically did studies on the leeches on diabetic foot cases, because previously was everything on flaps and grafts. There's only one particular study done in 2012. And you can see leech is actually to heal. It's coming from the phylum of Annelida, and it actually has an anticoagulant, which is known as hirudin, and they've got multiple hirudin-like factors. So when you actually put it in, basically, it has got 300 teeth, it attaches, and then it releases the hirudin, and that actually dilutes the blood and allows it to suck out about 45 ml of, 15 ml of blood only. And finally, at the end of the day, up to about 45 minutes, it drops off. And it relieves the congestion, reduces the pain, and also it's very cost effective. It only costs about, I think, maybe 2 ringgit, which is about 40 cents US cents. And the Malaysian leech used in this study was Hirunaria melensis, where we did a study with 20 over patients. And we found that, the good thing about it is previous leeches had problems because they had got infection in the gut. So we have to cover with antibiotics. But with the sterile leeches, we don't have to do that. And you find that basically the benefits actually outweigh the risk. So this particular leeches are actually, you put them on the eels and all that, and this you can see all kinds of bacteria, Proteus, Aeromonas, and also, Vibrio, Moraxella, Stenotrophomonas, Maltophilia, and all that, like this. So these are drug-resistant bacteria and all that. Now, using what we call is different solutions and also silver solutions and all that, we were able to actually sterilize the whole thing. So you can see under electron microscopy, basically these leeches are now what we call is sterile leeches. So we can apply it on the foot, and you find that a lot of difference basically. And this is a publication that we did on urotherapy in wound healing, basically, where we actually use on diabetic wounds in terms of looking at pain, swelling, and patients who actually found that they actually could walk better. And we actually apply only about 5 leeches per week. And you can see here basically application on patients who already had their toes amputated and all these things. By leaving the leeches, the feedback was less pain, less cramps, reduced swelling, and the wound started to heal faster. You can see basically completely the wound closed up. Because one of the problems that we have in diabetic foot is basically perfusion. So if you can have a localized anticoagulant, allowing the perfusion and the flow of the blood itself, it actually helps a lot. All right. And it's not so easy to actually do what they call this angioplasty or even endovascular work in patients who are in Asia, because most of our vessels are already atherosclerosis, having atherosclerosis, arteriosclerosis, and they're also very minute compared to the white Caucasians. There's another patient, same thing also. We apply the leeches on the peripheral areas of the one. You can see what you call that. There's reduced gradual cramps and all that. And finally, basically with wound healing itself. All right, the wound closed up. So with that, just to tell you, colleagues, that these are few things that we're actually doing, a lot of new studies. The good thing is basically these leeches are the sterile leeches. They are the ones basically which are the first sterile leeches in the world itself. So it's something that you can use, and it's very cheap, it's easily obtainable, and the technology is quite straightforward. All right. So one of the things is to always make sure that, your diabetic foot patients have got options. That means you need to have multiple things. So in Kuala Lumpur Hospital is the main tertiary hospital for the whole of Malaysia. So we actually receive most of the referrals here and all that. So we need to actually look at all these things and do more studies. Now, what I've shown you is a lot of real world evidence, because, when you look at evidence-based medicine, evidence-based practice, real world evidence is something alluded to by Shirley Wang in the British Medical Journal in 2020. And that actually tells you that that's what we as clinicians do. We see our patients, we look at case series and even case studies, and that's how we manage from our experience. So with that, I hope you have a wonderful session today. Thank you very much to Dr. Milind Rukia and the whole team for having me here. It's a pleasure for Abbas, Vijay, myself to actually support your education program. And I'm very happy that you're actually doing it for the undergraduates and the postgraduates and all that, because I think wound management in terms of even diabetic foot ulcer management is poorly neglected in most of the medical schools, basically. It's not actually, most medical students, nursing students don't actually go through the proper wound management, which we have lifelong, basically, in every single meeting over the world. So with that, thank you very much. You're muted, Milind.
Sir, you need to unmute.
Mute.
Yeah. Thank you, Dr. Harikrishna, for this talk on newer updates in diabetic foot. Many of us are not aware of these new things which are there, and you have so nicely told us with evidence. There is a question in the chat box which is related to your talk. Is about critical ischemia. Any newer updates on critical ischemia you can tell us about? And what is the prognosis in a diabetic ulcer? How do you decide about the prognosis in peripheral vascular disease? So that was the question in the chat box. You can take both of them together.
Yeah. I think what you call is peripheral arterial disease is becoming a big problem. I think when we were medical students about 30 years ago, about 10% of diabetic foot ulcers became neuroischemic. Now it's already up to about 40 to 50%. So we're seeing more and more cases of ischemia itself. Now, when you're looking at critical ischemia, that means ABSI below 0.5 and all that, you need to see them yesterday. That means you need to basically get the referral straight away to the vascular team. So we have got a vascular department basically in Kuala Lumpur Hospital. So they need to see them as quick as possible. And the thing is, whether you decide to do endovascular work or even basically a bypass surgery or what, it actually looks, you actually have to see the patient itself. Most of the time, I think the same concept basically in India and all that, patients come in late. And the thing is, if you want to put angioplasty and basically put stenting and all that, the stents are very costly. And what happens is, even for us with the budgets and all that, and basically with, a lot of our healthcare basically being subsidized and all that, we find the problem basically is they're coming in late. And that's the delayed referrals, number one. Number two, when they come in, basically, they are all actually more elderly patients and patients with multiple comorbids and all that. So it prevents a lot of this work with angioplasty itself. So one of the things that I would actually prefer basically is we need to make sure that, in terms of foot assessments, this has to be done. basically on every diabetic patients. And it shouldn't be just one time when they come to your center. Basically, even in the community, the nurses should be able to assess simple test. Basically, I mean, by feeling a pulse doesn't mean basically that the patient has got no peripheral arterial disease or peripheral vascular disease. You will still need to have Dopplers and all that. But having Dopplers is also a problem. But at least the basic concept of looking at the sign and symptoms should be there, and the assessments basically should be done. So at least, patients can be referred early. Because when they come in early, you can actually salvage these limbs. Now, the problem is when we talk about save lives, save limbs and all that, we have a big problem, especially when they're coming in late. It's all gangrenous and all that. And added on this, I think Vijay has also mentioned, even Abbas has mentioned about diabetic peripheral neuropathy. So they are numb. They have no feeling. So if you're waiting for an ischemic pain to come before they actually present themselves, because Paul Brand says pain is the gift of God to mankind. But the problem is, in diabetes, most of them actually don't have pain. So they don't come to you until it's all black and ready. And then at that time, they say, doctor, please save. You are God. You must save the leg. And that's when we have a problem because, the blood supply is not there. And it's very difficult to get in. And in some centers where they have got a proper team, I mean, a huge team, as soon as you enter the emergency department, they check whether got blood or no blood. If there's no blood, immediately vascular surgeon takes over. If there's sufficient blood, then the orthopedics guys or the foot and ankle surgeons, they will take over basically to look after these wounds. So that is good if you can do it in the emergency itself. But in most centers, we don't have all this. And you don't have, even in our centers, our vascular surgeons are very scarce. After they pass out everything, after a while, they go off to the private sector. So it becomes a bit of a problem. That's why now a lot of problem is basically in the peripheral arterial disease. That's why we need to have all these health clinics in the government side, private side, all that, to actually do proper food assessment for all these patients. You'll be surprised. We have got the green book where we actually make sure that, we assess diabetes and look at the food assessment at the back. And then we found that they were actually overlooking it. So finally, what we did, we moved the whole food assessment page to the front, and they still overlooked it. You see? So then becomes a big problem. So, and the thing is, there is a lot of things that people say can be done in terms of, stenting, in terms of angioplasty, drug, what do you call this, coated stents and everything else. But the problem and the most important thing here is basically, even with lasers and everything else, you need to go in early. If you go in when it's completely blocked, basically it's all the way to the femoral. So even fempops, whatever, might not even work, basically, because it's blocked all the way up. And every single vessel from the femoral to the popliteal to the anterior posterior tibial, all is blocked. We have patients like that coming in. That's another big problem also. So in that case, very difficult. And that case, you want to institute your treatment, your management and all these things. It is more only to see whether we can salvage the life. Most likely what you call is the limbs, you end up losing a lot of limbs. That's why you see the thing is from 30 seconds, when 20 seconds, it's now gone to 18 seconds. And I'm scared, even after Abbas finishes and after I carry on, whether to actually do a study on amputation. Because I shudder, we might actually end up with maybe 15 or even 10 seconds of foot is being amputated. So we're actually losing the battle because of the ischemic component now, especially. I mean, infection is there, yes, but ischemia together with neuropathy, and you add the infection, it's a huge Pandora's box, very difficult to manage.
So I thank the international speakers. At this note, only one question from the chat box to any one of you can please answer is how important is ankle brachial index in critical ischemia?
I think, Milind, I would just like to add to what Professor Nair said about peripheral arterial disease. So we have saved several limbs which are ischemic by doing what is called digital subtraction angiography. I agree with Professor Harikrishnan Nair that the blood vessels are proximal and difficult to do and so on. But we have developed this concept which we presented in DFSG last year, where this concept of blood flow to the area of the ulcer, wound blush, it has been described in the heart. But we did digital subtraction angiography, and those who had a poor blood circulation to the wound, to the ulcer area, we put in a stent and we would we remove the gangrene toe, but we save the rest of the feet. So digital subtraction angiography has come a long way, and it costs about 1 crore in India to have that machine. installed in your hospital, but we did it and several years ago. So I think digital subtraction angiography (DSA) has come a long way, and it is using less dye than the CT or MR angiogram. It is using less dye. So I think the DSA is come, and ABI is a good way of screening, as I told, as Harikrishna said, the community, the nurses should screen for the pocket Doppler, with the hands, the dorsalis filus and the posttibial, and also with the ABI. You have the 1 minute ABI now, 1 lakh. So I think it's possible to diagnose peripheral arterial disease early enough in India, in the developing world, if you have the capacity to do it and the people to do it. Thank you very much.
Thank you, Dr. Abbas, Dr. Vijay, and Dr. Hari for joining. And I know that we have already discussed that you'll be logging off because of it's a working day, but that's okay. Thanks for these very good inputs and different ideas from internationally that we have got in this conference. And all of you have appreciated this Catch Them Young program, and we'll hope to continue this in different parts of the world. Thank you so much.
Thank you.
Yes, sir. We move on to the national speakers now, and the first in the thing is Dr. Tushar Rege, who's going to speak on role of applications of local applications in infected diabetic foot. Dr. Tushar is a wound care specialist and diabetic foot surgeon from Mumbai. Is diabetic surgeon to the governor of Maharashtra, president of IPA, Indian Podiatric Academy Maharashtra chapter, and currently he's running a diabetic foot center in Dadar, and he is the first to be awarded fellowship in diabetic foot surgery by the MUHS. So we will see what Dr. Tushar has to say about this local applications in diabetic infected wounds. Tushar, over to you.
First of all, thank you, Dr. Milind, for inviting me here. And it was nice in the company of Dr. Abbas, Dr. Harikrishnan Nair, Dr. Vijay Vishwanathan, and all the national stalwarts as well. I have a very simple thing to talk about, and a lot more complex things would be talked about by the subsequent speakers. I'll just touch about the topic, Milind, which you have given me, and that is the role of mupirocin and metronidazole in diabetic foot infections. And to give an overview, a few things about the facts and figures which everyone has been talking about. And just now, the speaker previous to this said that we were talking of 30 seconds a limb is amputated, and now it may be 15, and in 10 seconds a limb will be amputated. That's how we are looking at the problem. And the most important thing in this slide is by that last statement that 85% of all extremity ulcers are extremity amputations are preceded by an ulcer. So we are really looking at a big problem with a lifetime risk of 25% in all diabetic foot ulcers. So this is a huge problem which we are looking at. Since you have given me the topic of local applications, Milind sir, we are talking about dressings. And dressings evolved right from dressings with honey. And when they found antibacterial properties of honey, they started testing all these phytochemicals and found that they were effective in inhibiting or suppressing the growth and proliferation of organisms on the surface of the wound. What was most appalling at that time is that a change of pH actually affected wound healing. And they found that even in simple things like honey, the pH was not altered even because of those organisms. And this had a long way in testing honey as an antibacterial. Now, why I'm saying honey as an antibacterial? Because over a period of time, other antibacterials or local agents started coming into the play. One such thing was iodine. Till a great time when we were students, iodine was a big thing. Everyone used to use povidone iodine. And then started coming controversies that in India we were using povidone iodine which was 5%. In the Western countries they were using povidone iodine which is 10%. And over a period of time then they started showing that povidone iodine is tissue toxic. It creates toxicity to the tissues. And therefore other agents started being tried. Then came silver. In silver again, they tried to micronize the silver, making it colloidal silver, which was again large particles and therefore a lesser surface area. And then they tried to get in ionic silver, where ionic silver was very small particles and therefore a large surface area could be covered by these ionic silver agents. Then they started showing then they started showing papers where they found that silver also was not completely safe to the tissues. So this evolution has been a big thing in local applications, that no particular thing had stood the test of time. But what was important is that over a period of time, people started realizing that infections were not monomicrobial, they were polymicrobial. And this is one slide, I think, which is an important slide which we have to realize, that all skin and soft tissue infections, by and large, will start with gram-positive organisms. It's a simple infection, gram-positive. Over a period of time, the infection starts being invaded, or the tissues start being invaded by gram-negative bacteria. And as time passes by, there is a propensity of anaerobes in this infection. Towards the end of this slide, you will also see that what starts as a neuropathic infection or just on a neuropathic foot starts becoming invaded by gram-negative or anaerobes because of a certain amount of ischemia, which may be the inherent ischemia in this particular patient, or as a result of microthrombi, that wounds start getting infected and thereby there is local ischemia, but anaerobes start becoming an important part of this infection. The relation between aerobic and anaerobic is again synergistic. That means because of one infection, and this is of course something which we see in biofilms as well, that one infection actually promotes another infection. There is another slide which shows something similar, that because of these bacteria taking away significant oxygen from the tissues, it is that the anaerobic bacteria start thriving and anaerobes keep increasing. And thereby, we are talking of this combination of mupirocin and metronidazole. Mupirocin is an excellent application which takes care of gram-positive and gram-negative bacteria. Metronidazole is excellent for anaerobes. For a clinician, a foul-smelling wound also will contain anaerobes, and therefore this combination of mupirocin and metronidazole is the treatment of choice whenever there is infection. I think my time of 8 minutes is about to almost end in the next 1 minute. I'll rush through the next of slides which are more of microbiology, that we have gram-positive, gram-negative bacteria, anaerobes which come a little later, and there are a lot of guidelines which are given to classify diabetic foot infections, on antibiotic therapies for mild, moderate or severe infections. There are antibiotic regimens which are given for again mild, moderate, severe infections and for bone infections. And there are adjunctive therapies or associated therapies. Some of it have been discussed, like hyperbaric oxygen, maggot therapy, negative pressure therapy. But topical antimicrobials is something which is simple. And when we were talking of educating people, then people who are not actually going to operate have to be aware of such topical local applications. Biofilms is an important thing, but I think this is going to be discussed subsequently, where there is a film containing bacteria which will prevent the penetration either of antibiotics or local applications into the tissues. Biofilms is now a very big thing, which is something extremely important in wound healing. There are a lot of studies which are conducted in India. This is a study in Bangalore, this is a study in Chandigarh, and this is a study in Latur, only to tell you that across rural areas as well as the urban areas, we are talking about a mixed infection of aerobes as well as anaerobes. Give me a minute, Dr. Milind. So, this spectrum, which shows that there are infections related to aerobes, gram-positive, gram-negative, as well as anaerobes, brings us back to something important, and that is a combination of local antiseptics, which will cover the gram-positive, gram-negative, and the anaerobes equally. What is the take-home message? The right antiseptic is to be used for the right type of wound. For instance, if there is a wound with a lot of slough, just using antiseptics will not be useful. You have to have something which is papain-based ointment. But anyway, that is not the part of the talk over here. So the important thing is the right local application for the right type of wound. Then detection and early education is again an important takeaway message. But we are all surgeons here who are talking now. And the gold standard or the most important takeaway message is a radical debridement. If a radical debridement is done, then the local application does not matter at all. But when we are talking of on a very, very wide range, where we shall have physicians treating wounds, we shall have general practitioners treating wounds, we shall have local health workers treating wounds, then it is important that a broad spectrum antiseptic is something which is extremely important as a local application. This was a small presentation, ladies and gentlemen. It is only to tell you that a particular combination of mupirocin metronidazole will have a wide coverage, especially in wounds which are neuroischemic, but that does not mean that that is the only application. The most important thing is treatment of the diabetic foot ulcer as a whole, as a result of which we can actually execute a limb salvage. Thank you. Thank you so much.
Dr. Tushar, thank you for a lucid lecture on local applications. My question would be, when you do the debridement, which is the gold standard, how do you decide what local application you are going to use?
Dr. Milind, the most important thing is, as we said, and we all as surgeons know, that a radical good debridement is extremely important. If I'm sure about my debridement, that means that I have almost eradicated all visible necrotic tissue, then vacuum assisted closure is my treatment of choice following a good debridement. But there are some things where the line between a good debridement and an amputation is not very clear. For instance, if there is a lot of necrotic tissue adherent to the joint capsule, to the bones, in between the joints, that is the time when ideally I should be amputating. But if I have to prevent or save or try to prevent an amputation, then at that time, I would use something like a papain-based ointment. If I feel that infection is still present, of course, it's a wrong way to say infection is still present, because ideally the debridement should have been complete. But if there is some amount of infection, then a local antiseptic would be the treatment of choice.
Okay, thank you, Tushar, for a nice coverage of this topic. We move on to the next speaker, who is Dr. Manisha Singh from Gwalior. So she's a consultant diabetic limb salvage surgeon from Gwalior Diabetes and Foot Care Center. And she has presented a lot of papers in national and international conferences, written chapters in international textbooks. She was the organizing secretary of the first midterm DEFCON and invited faculty to various conferences. And Dr. Manisha is going to speak upon the negative pressure wound therapy. Has it revolutionized the diabetic foot management? Over to you, Manisha.
Thank you, sir, for the invite, and thank you for inviting me for this esteemed forum. My moon greetings to the galaxy of international speakers and the national speakers. And I shall be speaking on the role of negative pressure wound therapy and how it has revolutionized the scenario of diabetic foot management. So I hope you can see the...
Yes. Go ahead, Manisha. Dr.
Yes,
Manisha, you can go ahead. Yeah.
Yes, sir. So we know that the incidence of diabetes and diabetic foot is on a significant rise, and the most devastating complication is the diabetic foot ulceration, which when gets infected, it has a very high post-amputation debility and disability and increased mortality, particularly in the patients with chronic renal disease. It is the hyperglycemia of diabetes which leads to the which contributes to the delayed and non-healing ulceration by increasing the cell apoptosis, local histiocytic oxidative stress rise, and excess inflammation, which disables or reduces the skin fibroblast activity and delays the wound healing, apart from the formation of biofilm, which Regis has already discussed. So this will prevent the wound contraction, epithelialization, and provoke the inflammatory response. So everything should be done to heal the wounds so as to prevent the amputation and related disability. So the International Working Group of Diabetic Foot has announced that it is the best one of the very prominent and best adjunct to standard of care for the treatment of the post-surgical foot wounds in the recent guidelines by IWGDF. And the NPWT is found to promote the or enhance the wound granulation, shorten wound durations, healing times. So it is very widely used, and tremendous progress has been made in its wide application and research in the last 20 years, when it started initially as a cupping therapy and using glass cups. So a wide variety of studies have also been done, consensus guidelines have come up, and with the recent consensus guidelines in 21, a revision of 2001 guidelines and 2006 guidelines, we have the recent guidelines where the level of evidence and grade of recommendation are still, they are not so high, and a lot of randomized clinical trials are needed. So the treatment of diabetic foot wounds is a cross-disciplinary and needs a very systematic or organized approach to heal it. And NPWT is one of the very important adjuvant or the adjunctive therapy, which will, but it has certain prerequisite conditions like wound infection should be well controlled, the risk of bleeding is well controlled, and potential bleeding and the wound infection should be controlled. And during debridement, prior to its application, we should take care that the infection and the hidden foci of infection, the fascias, they should be taken, they should be checked for the presence of infection and should be eradicated during debridement. A good culture, deep tissue specimen must be sent for the culture, and biopsy of the wounds must be done so as to see the evidence of healing. The risk of bleeding should be well controlled. Potential bleeding and the INR potential and coagulation profile should be taken care of. The INR should be in the range of 1 to 2 should be done prior to application of the VAC. And because with the application of negative pressure and higher negative pressure, sometimes there may be the risk of ischemia should also be well controlled. There's adequate wound and distal limb perfusion should be checked before. TCPO2 should be more than 40 range. ABI should be 0.9 to 0.3 or TBI more than 0.6. So other parameter settings which include the negative pressure should be ranging from between -125 and -80. And for vascular and stenotic lesions, we'll have lower pressure range between -80 and -60, and these are recommended so as to prevent the bleeding. The mode of NPWT should be maybe either continuous, intermittent, or variable mode, but better results have been obtained with the variable mode. So the continuous mode, to understand, is a continuous mode where the continuous pressure range is stable, that is either somewhere between -125 or 80, and the pressure, negative pressure, remains consistent and stable. This is less commonly used now because of the pain it causes, and maybe not be acceptable by the patient. But the intermittent mode, where there is the 5 minutes on and 2 minutes switch off, so there is sudden increase and lower of the patient, which again is very uncomfortable for the patient. And the new one which has come up is the variable pressure therapy, where there you have a certain negative value, so it may be between -80 and -10 or -20. So it is more comfortable for the patient. The pain is less, and it maintains a uniform negative environment. So apart from the specific the specific applications of NPWT according to these guidelines may be infected wounds, where I've already told, and wound osteomyelitis, where it should be used with caution, and continuous close monitoring of the wound is necessary, looking at the wound edges, wound margins, the color of the wound, if there is any bleeding or pus or exudate or foul odor should be looked into. So a lot of caution is needed after skin graft or flap transfer. Continuous negative pressure should be maintained for 5 to 7 days. Similarly, for the grafted wounds, also with dermal equivalent, similar consistent pressure may be maintained for 3 to 5 days, negative pressure. And after extremity or toe amputations with conditions of primary suture, we have to maintain continuous mode of thing for the -80 to -60. And in ischemic wound, it has to be again done with caution, and lower pressures have to be started, and the wound monitoring is essential. So wounds after extremity or toe amputation without the condition of primary suture, we use lower pressures, and it is recommended in Wagner's grade 2, 3, and 4, but not recommended in grade 5, 1 and 5 diabetic foot ulcers. So the primary to understand the mechanism of the NPWT working, it was Moriqua's animal model was used as a facilitator, and for the ideal wound healing, to provide the ideal wound healing environment. And with NPWT, there is actual indrawing of the wound edges to bring it together to ensure that there is wound contraction, and there is the wound is cut off from the surroundings with the help of the plastic cover or cellophane, so it maintains the reduced microorganism or no microorganism level and amicable environment for the wound healing, reduces the wound edema by washing away the exudates, and there is micro deformation to stimulate the bed of the wound for cellular proliferation and angiogenesis. So the secondary effects may be stimulation of the cell proliferation, release of growth factors, and reduction of the inflammatory cytokines, increased angiogenesis, indrawing of the blood from the periphery of the wound, reduction of inflammation, and enhanced granulation tissue formation so as to decrease the bioburden. So NPWT is a great modality and has expanding dimensions almost in this scenario, in the wound healing area. And again, as we have already seen, you have to carefully select the wounds, and debridement prior to the application of VAC is essential, and wound biopsy and wound deep tissue should be taken for the culture. You have to rule out, you have to see whether there is wound ischemia or there is an infection, osteomyelitis, or sensory neuropathy. And so debridement should be radical, and it should be free bleeding edges should be there. So the common goals of NPWT is to promote rapid reduction in the wound volume, promoting wound contraction, growth, enhancing the granulation tissue, prepare the wound bed for another procedures like skin grafting for wound cover, and reduces the bacterial count and decreases the overall hospital stay length. And it may be even economic in this way, that it reduces the hospital stay length, even though the initial cost may be higher. So it decreases the frequency of dressing change also, and very comfortable comfortable for the patient, prevents the wound deterioration and contamination, wound odor, improves the quality of life. So, but we are at the application, as I've already told, we should also not only inspect the wound and monitor the wound throughout the process, but also do the preliminary healing markers like hemoglobin, albumin, pre-albumin, WBC count, creatinine, and appropriate antibiotics, initially broad spectrum, followed by the culture-specific antibiotics must be given to the patient. So, what are the indication or when we should do the NPWT? The recommended for mains powered negative pressure wound therapy are usually the acute and the subacute or the traumatic wounds in general, and the pressure ulcers, large pressure ulcers, venous stasis, large venous stasis and painful ulcers, meshed grafts, and adjunct to skin graft and flap procedures. Almost same for the battery powered ambulant negative pressure units or for home care, etc., where it's mainly not the acute wounds we are not dealing, but almost the same things we are doing. So it can reach the home comforts also with the use of portable NPWT devices. And this is the our NPWT device which I am using at my center, and it is made not a very big company, but it is giving this is a battery, and you can see the entire appliances which are needed, and you can have a battery, a canister, the tubing, and then you have a connecting tube, you have a foam, the sealant, and small tubing connector to be there. So the Y connecting tube to connect two places if the vac is at two places, and the suction pump. So you can see it, and you can, with the help of the this thing, you can change the settings with the help of the buttons. And also it is battery powered. So with the foams which are used are very important, which help in the growth of the granulation tissue, and they're in direct contact with the wound bed. Polyurethane foam it gives the fastest granulation, but it has larger pore size, and hence the granulation may grow into it, making it very painful. Also, it may even cause ischemic necrosis by blocking the smaller vessels and hardening them. So this is usually less recommended, but it causes thick and faster granulations, but there are more chances of fibrosis after using with thick granulations. So you get a thick granulation with PU foam. Polyurethane ester, where it is more used in the instillation vac and removal of thick exudate material like fibrin, slough, and thick vac exudate and other infectious material. It is used, and it also has a honeycomb structure, which allows the ingrowth of the granulation tissue, but to a lesser extent than PU foam. Another is polyvinyl foam. It's also hydrophilic, more elastic, and it's also used for the same purpose. But we prefer, nowadays we have gone over to the gauzes which are impregnated in PHMB solution or any other saline soaked gauze, which can be moistened and used, and it allows more stable granulation, does not allow the ingrowth of the granulation tissue, and removal is easier, and it's more comfortable for the patient, more cost effective also. So this is the application seen at more than 1 point for the extensive debrided area. You can see how it is applied, and you can see that. So now the application, we can see that initially the wound is inspected carefully apart from at the bedside, then it is cleaned thoroughly, and after a thorough cleaning, watching the web space for infection, we then cut the foam to the size of the wound. It should not go outside the wound confines, and then apply it on the wound area, and then we apply tincture-benzoin around it so as to allow the sticking of the cellophane or so that sheet that seals the wound, and then we can see that how it is used. Cellophane sheet is applied over the tincture benzoin, which is applied to the surrounding edges of the outside the wound edges, and then a small hole is made over which we can keep this eyelet, and then it is attached to a tubing. So you can see that, and then once it's attached to a tubing, it's attached to the suction pump, which I had already shown you, and the settings are adjusted. So the pressure, cycle, and duration I've already spoken to you, and it is important that in the wounds which are ischemic or having the skin grafts, in the skin, those with ischemia and infection, mild infection, we have to give a relatively less suction to them, and also those which are the wounds which are larger need more negative suction, and then the wounds which have the which are grafted or even the skin tissue equivalents are applied, dermal substitutes are applied on those wounds. We apply a low level of intermittent suction to them, that is 5 minutes on and 2 minutes off. of intermittent suction or a variable mode of suction that is preferred. Initial consistent negative suction is applied for 5 to 7 days up to a week's time in the patients in whom dermal substitutes are used or the grafts are applied. For dermal substitutes, even 3 to 5 days continuous suction is enough. And those wounds with vascular occlusion or stenotic lesions, we use a lower pressure range like 80 to 60 depending on the size of the wound and the need of the need as per the need of the patient. So we can see also take into account that which apart from which wound filler and what pressure to be seen, we see that that antibiotic has to be taken. Which antibiotic we are giving, whether the patient needs home care or portable devices can be used. So again, as I have told that in the wound periphery, the blood flow actually increases after 2.5 centimeter from the wound edge. So as to draw more blood to the wound area. Then immediately in contact with the wound edge, the blood flow actually decreases so as to enhance the angiogenesis and the granulation tissue formation. So this is how the NPWT works and increases inflow towards the wound area by exerting negative section. So complications can be, the most feared complication is the bleeding, spread of infection, maceration of the surrounding edges. And these may be, the maceration of skin may be due to technical issues of leakage, etc., or more pus forming suddenly, spread of infection, and bleeding may be there. So the long-term, short-term complications may even include severe bleeding and pain and rupture of the heart, and in long-term may decrease the quality of life or even malnutrition. So the when to discontinue NPWT is that when you have achieved the desired goals for the wound and you have to you have the effective or the very excellent granulation, very effective granulations, less effective and non-effective wound bed. So depending upon the amount of granulation and angiogenesis, we decide that, and exudate volumes have reduced and the wound is prepared for the graft. So failure to improve in the wound, we have to stop it. And again, the complications are developing like bleeding, etc. We have to stop it. Poor patient command, patient is not tolerant, reducing with pain, blister formation, allergy under the cellophane sheet, they will not tolerate it. So we have to avoid in this in these patients. So if they're exposed blood vessels, they're malnourished patient and there's malignancy, and then we have to usually discontinue, or work should not be put at all. So these are the single-use portable negative wound therapy, or the PICO, and then it is battery-powered, disposable, and does not require a canister and delivers approximately. So these are the refined wax which are coming out depending on the need of the patient. And it has been smaller trials shown to be non-inferior as compared to the traditional NPWT system. Then we have another irrigation wax, which also reduces the bioburden by dilution of the inflammation and also enhances angiogenesis. Intermittent application may be good. There will be washing installation. Saline installation is the best method, best solution. Here also saline is the recommended first line solution by the panel, and even PHMB is is good tolerated, but it's a little bit carcinogenic effects have been suspected for it. And these are the combination therapies where we are in a relatively neuroischemic ulcer, we are doing the debridement, applying the VAC, and then followed by SSG. And then there may be even topical oxygen ozone may be given. The irrigation this thing, apart from installation irrigational VAC, apart from installation of the so antiseptic solutions or saline, we are also using the oxygen supply in installation VAC. Similarly, topical oxygen ozone first to bring the granulations, and then followed by VAC therapy to increase the number of oozing points. So it may be gene expression through differential gene expression it may cause, and this improves the epithelialization and angiogenesis, and so its effect has been studied in animal models and preliminarily in humans in preliminary stages. Then again, wound margins, we will find that upregulation of the deoxyradixin, and then it is premature. In the rat model, it has been studied, and it has promotes by reducing the oxidative stress and improving the proliferation and migration apoptosis is this will promote the wound healing. So effect of negative wound pressure and wound therapy thermometry has been done, and they studied the various parameters related to wound size reduction and found the sufficient difference in the baseline and the day 21 values. And in this study, they also found that patients were highly satisfied with the NPWT compared to the conventional dressing, and the cost of treatment overall due to reduced hospital stay was much better. So concluding, I would say that NPWT has revolutionized the treatment of non-healing wounds, and it has a significant effect on the limb salvage. For better outcomes, we must do the guidelines and recommended. We must follow them, because the irregular application of WAC may lead to serious outcomes. So improved outcomes in infected wounds with instillation nanocrystalline antimicrobials has been found. With change in pressure, mode, and duration setting, NPWT can treat most of the wounds, and it can enhance the healing and lead to wound closure. Portable devices and home care protocols are expanding usage outside the hospital settings, and it is an essential tool in overall multidisciplinary or cross-disciplinary management of the diabetic foot. Thank you, sir, for the patient hearing. Can't hear you, sir.
Thank you, Dr. Manisha, on such a detailed lecture on diabetic foot management by negative pressure wound therapy. Constraint of time, we'll take all the questions in the end. I think we'll move on, Dr. Jai, to the next.
Thank you so much, Dr. Manisha, ma'am. I think it was a very comprehensive talk on NPWT, and we request you to stay back so that we can have all the questions at the end. And we request all the viewers and all the postgraduate students who are watching us live from different part of the country, please post your questions so that we can have a fruitful panel discussion at the end. And with this, I request now our program director, Dr. Milind Ruke, sir, to take us through a very new and a very differential topic coming up next. Is on Carexom iodine, a new agent in a biofilm management. And now, without much wasting time, would like to now hand over this platform to Dr. Milind Ruke, sir. Over to you, sir. Thank you so much.
Okay. So at this point of time, I would like to welcome and appreciate Dr. Abhay Darvi, sir, who has joined, who is the MMC observer. Thank you, sir, for joining.
My pleasure.
Thank you, sir. Jai, I would like to start my last talk first, because one of my talk, which was now on biofilms, I will take last.
Sure, sir.
So I'm going to talk on the use of skin substitute in diabetic foot wound management. And so diabetic patients and wounds in diabetic patients are associated with neuropathy, peripheral vascular disease, and diabetic foot infections, as we all know. And what we have seen when treating these diabetic patients is a lot of impaired healing, prolonged inflammation, and reduced epithelialization kinetics. So the wound contraction and the wound healing is more suffered when you have a large area of skin which is lost with the loss of dermis. This is the emerging phase of diabetes longevity, and we see large wounds now, especially in government hospitals and late referral patients. And most of the time when we debride this wound, they exhibit a phenomena called as iceberg phenomena, where we find that the wound is small, but once we start debriding a large area of the foot, we have to debride where mostly the epidermis, the dermis, and even the muscles are compromised. So does the dermis skin regenerate? After a deep skin injury in mammals, the wound heals, but the dermis cannot regenerate. Instead, collagenous scar tissue forms to fill the gap in the dermis, but the scar does not function like the dermis and often cause disfiguration. Now, we all know that the advanced glycation end products, they cause glycation of the tendons and the ligaments of the foot, and that causes altered biomechanics. So with the dermis gone, once you are trying to reform the foot or reconstruct the foot, it's very difficult only to put a skin graft or allow it to heal on its own. It will cause a lot of fibrosis. So closure of the wound and offloading is important in association with assessing the vascular condition, modifying glycemic control, debridement, applying different kind of moisture spread and time principle, which we are already doing. So we are going to now today discuss on this aspect of what happens when you have a large wound and the dermis is lost. So initially we used to do local rotation flaps, pedicle muscle flaps and free flaps. They require strict post-operative management and offloading to eliminate repetitive shear forces, pressure, and premature. Now, local flaps I do in my practice, where we replace the like tissue by rotating this flap in small, but we have also done in large wounds. In a heel ulcer where the entire ulcer is excised, and then we rotate the medial plantar flap and we have good results. We have also done the sural artery flap where non-dependent area muscle with the skin and subcutaneous tissue is transferred to the dependent area. But this requires a lot of expertise, and most of the places and with medical legal things, we require either a trained diabetic foot surgeon or plastic surgeons to be around to do these cases. And in secondary care hospitals, now we are expanding our medical education and medical teaching in hospitals. So in secondary care hospitals, these facilities are at least this point of time not available. So we have seen now new evidence of bioengineered skin substitutes being used, like amniotic membrane, autologous stem cell therapy, fibroblast-derived dermis, and porcine small intestine submucosa, which has been used, and they play a significant role in the management of diabetic wounds by providing a scaffold for tissue growth and promoting the heal process instead of doing flaps. So we have graft jacket, Epicel, Appligraph. Now Appligraph is not available. It's a bilayer thing. It's got epidermis as well as dermis, which can be put, but it is not available. So we have Dermagraft, where human fibroblast and polygalactic scaffold, which is artificial, is used. Got Integra, again a bilayered with a silicone layer, which is then removed later on after you graft it, and Matriderm, which we are using now in collagen scaffold. The evidence shows that the treatment with Dermagraft produced a significant greater proportion of healed ulcers compared with the control group, where we have done skin grafts or just allowed the VAC to heal the wound, or with only applications of growth factors. Now, these are some things that we used to do before using the dermal grafts. So no dermal substitute was used in this patient. Patient was not willing. So this was osteomyelitic. We had to remove the great toe. After removal, we had to do a graft from here. But because the dermis was not used, dermal graft was not used, this patient returned after about 6 months with a ulcer or a skin loss. The absence of the dermis leads to fragility, blistering, scarring, and poor cosmesis. The dermis is vital for elasticity and mechanical strength, and hence a dermal graft would have helped this patient in wearing a offloading shoe and doing his routine work. This is another patient, a 56-year-old man, non-diabetic, a meat seller, very poor, comes referred by a general surgeon. Patient comes to our center with high pulse rate, frank gangrene with severe pain, ABI 1.2, luckily. So you have to have a good blood supply if you are putting a Matriderm. So this patient, as an iceberg phenomena, you see this redness is spreading to the lower leg, and he was advised below knee amputation. We did an debridement. The patient was not willing for amputation. And slowly, after about 3 weeks, we had the wound this way. So we put an installation vac and we achieved a granulation tissue. We grafted him. He was very good during the COVID process. He did not walk much, but the moment he started walking with the offloading footwear, he was okay. But even after using a footwear, he developed this kind of ulcer in the 1.5 years. So if we had used a dermal, this is the retrospective thinking, it would have been helped. So we reviewed in the secondary care municipal hospital systematic meta-analysis things, and we found that compared with standard care, the acellular dermis matrix use was very beneficial for the patient, and it was also superior to Appligraft. So we tried to do 24 cases in our setup. The initial thing was to do debridement. We used mechanical debridement, surgical debridement, and removed all the slough and necrotic area. This is a schematic representation. Then once the skin substitute was ready to be put, we also used in some cases negative pressure wound therapy. Then this substitute caused stimulation of cellular influx, extracellular matrix deposition, and reepithelialization. The graft slowly broke down and the remodeling occurred in patients. So this is one case, very bad osteomyelitis spreading across the midfoot up to the lower leg. We had debrided initially, and then we had to take the extend the incision up to the above the ankle, and then we put this is the dermal graft that we have put. This caused, and the second sitting we put a skin graft over it, and the patient 2 years free from any kind. This is a very interesting case. This is a typical iceberg phenomena. Patient comes referred by a physician, sugar very high, and he had a wound with communicating sinus to the lateral part of the foot. We found calcaneal osteomyelitis. We had to do the arterial Doppler. We found 1.2 as the ABI index 1.1. And then we did serial debridement. Every time we used to find pseudomonas. We used cadexomer for it. Sometimes we used VAC. We even drilled the calcaneal bore, did a partial calcanectomy, put cadexomer powder this time, and we found a good granulation tissue, which we again whacked. This is the dermal graft on the bone we have put. This is skin graft, and this is how the patient is after. So he has done very well. Last 3 years, he is not recurrent. This is a non-diabetic patient who was treated by a variety of hospitals with a large wound and a very ugly kind of thing, which is extending from the dorsal to the plantar area. And nobody had a clue. Last 32 years, he was suffering from this, not walking on this foot. We did an edge biopsy, 4 edge biopsies, and we thought it was malignant, but it was not. And we did a good debridement of this patient. And we found that the 5th and 4th metatarsal head had osteomyelitis all these years. I don't know why it had not spread up, but that is how it was. And on the bone, after debridement, the healthy bone, we put just a 3 millimeter matridum patch. And in the second sitting, after 3 weeks, we put a skin graft, and we had no 1 year, and he's been working for the thing. So dermal substitutes in case with dermal damage, relying solely on the best epidermal substitute isn't sufficient for optimal wound healing. The absence of dermis leading to fragility, blistering, scarring, and poor cosmesis. Dermis is vital for elasticity and mechanical strength while walking. Dermal reconstruction becomes crucial when the original dermis is missing. Additionally, only 15% to skin graft successfully integrate the wound and have total healing. And the fibrosis caused by it, especially in the plantar of the foot, is not will cause a problem or a recurrence of ulcer. So ideal properties of skin substitutes, whichever you want to use, should have improved host tissue regeneration, barriers protection and resistance to local infection, resistance to shear force when you're walking in a modified or customized shoes, improved cosmesis, easy handling and application, long shelf life and cost effectiveness. So in summary, skin substitutes present a promising avenue for treating diabetic wounds. These substitutes offer advantages such as accelerated healing, reduced infection risk, and improved tissue regeneration. Cellular substitutes contain living cells like fibroblasts and keratinocytes, aiding in wound healing. So, I think this is a good thing if you don't have a plastic surgeon around, especially in primary and secondary care center for general surgeons. Thank you. So I think we'll take questions after the next two lectures are by a very skillful surgeons, one from Coimbatore, Ganga Hospital, Dr. Madhu Perasamy. They are going to demonstrate surgeries which normal general surgeons do not venture into or do if they are not trained. And the first lecture is going to be by Dr. Madhu Perasamy. He is from Ganga Hospital, and he's a consultant plastic and wound reconstructive surgeon. And he has got a lot of publications under him. And he's going to talk on Keller's osteotomy for ulcer on the plantar aspect of the great toe. Over to you, Dr. Madhu.
Thank you, sir. So the topic for today is Keller's arthroplasty. So I'll start sharing my screen now. So the Keller's arthroplasty is it's a gap arthroplasty. I'm not sure if an arthroplasty for particularly for general surgeons means it is an operation by which we increase the function and mobility of a joint. So this operation is specifically for treatment of the great toe IP joint ulcer, particularly this ulcer. The other type of great toe ulcer is the tip or subungual ulcer, about which we are not going to talk today. Great toe ulcers by themselves constitute about 30% of all diabetic foot ulcers. And hence, treating the great toe ulcer alone has a potential to reduce the number of amputations by 1/3. So, to talk about this ulcer, we need to know about the pertinent anatomy of the great toe. The great toe is the largest of the 5 digits. It consists of 2 phalanges, just like the thumb. It consists of the proximal phalanx and the distal phalanx, whereas the other toes consist of 3 phalanges. So it has only 1 interphalangeal joint. The other toes have 2 interphalangeal joints. So the outermost plantar layer of the great toe is the plantar skin and soft tissue, and particularly an abundant amount of plantar fat pad. And this fat pad, as you can see, is modeled in a 3-dimensional way so as to increase the contact area and reduce the pressure on the underlying plantar skin. So once we go through that, you can see that the next layer in the sole of the foot is the plantar fascia, which extends. There is a slip extending onto the great toe. So this plantar fascia is like a continuation of the Achilles tendon with this with the calcaneum acting like a sesamoid bone so as to turn the forces of the Achilles tendon in a plantar way to the forefoot. So it transmits the it is a structure that helps to retain the arch, and second to transmit the forces of the Achilles tendon to the forefoot. So once we go deeper to that, You have the first layer of the sole with the flexor digitorum brevis muscle in the center, the abductor hallucis on the medial side, and the abductor digiti minimi on the lateral side. These are all called intrinsic muscles. Intrinsic muscles meaning they arise in the foot and insert within the foot. The other type of muscles are that act on the foot are the extrinsic muscles, particularly the long extensors and long flexors, which come in the second layer of the sole. So these are muscles that originate outside the foot but insert into the foot. So these are called extrinsic muscles. So these are mainly the components of the second layer. As you can see here, the flexor hallucis longus, the flexor digitorum longus, and an important structure between them, which is the knot of Henry. So that is why it is very difficult for you to flex your great toe alone without flexing the other toes. So anytime, even as you are watching this program, you can try flexing your great toe alone. You will notice that all of your other toes also flex. It is difficult to, it is near impossible to flex your great toe as an isolated flexion. So the other components of the second layer include the lumbrical muscles, which arise from the long flexors and insert into the extensor expansion, and the quadratus plantae muscle, which serves to, just like the skin hook, it serves to turn the direction of the pull of the long flexors from the medial to a more central direction. So this is the quadratus plantae muscle here. So when we pass on to the third layer, you can see now that the muscles of the great toe take more prominence here. So the third layer, all of the muscles are to the great toe. There are two heads of the flexor digitorum, flexor hallucis brevis, the tibial head and the fibular head, with the FHL passing in between them. The FHL is part of the second layer. So these muscles just lie underneath the FHL. The other muscle is the adductor hallucis, which again has two heads. It has a transverse head and has a oblique head. All of these muscles to the great toe, they insert onto their respective sesamoids, and from there through common intrinsic tendons into the base of the proximal phalanx. The third muscle is the flexor digitorum minimi muscle, which inserts into the base of the little toe. And the fourth and the deepest layer, here the muscles of mostly do not go into the great toe. They are the plantar interossei muscles and the tendon of the peroneus longus, which inserts into the base of the first metatarsal. It is important in allowing the great toe to dorsiflex, because it causes a plantar flexion of the first metatarsal, so that the great toe can easily be pushed up against the first MTP joint. So on the dorsal side, there are only two tendons that insert into the great toe. All of the extrinsic tendons will insert into the distal phalanx, whereas all of the intrinsic muscles, particularly on the dorsal side, the extensor hallucis brevis, will insert into the base of the proximal phalanx. So on the plantar side also, it is the same. All of the intrinsic plantar, the flexors will insert into the base of the proximal phalanx, whereas the extrinsic muscles will insert into the distal phalanx. So once we go from there, now we need to know about how exactly the great toe helps in walking. So unless we know about that, we won't be able to understand why this operation is necessary in patients who have an ulcer. See, during walking, there are mainly two events that occur. These are called phases of gait. There is a stance phase during which the involved muscle, the leg, is on the ground, and a swing phase where the involved foot is off the ground and it is swinging forward in the air. So there is a difference between walking and running, and it's not very important to know that here. You just need to know that there are two phases of gait. One is the stance phase and swing phase, and all of the forces that cause ulcers act on the foot during the stance phase. That is when the foot is weight bearing. So for that, we also need to subdivide the stance phase into 3 periods, where the initial period is where the foot hits the ground as a dorsiflexed foot. A dorsiflexed foot which hits the heel, there is a heel strike, and which goes on to become a plantar flexed foot. So here it becomes from heel strike to foot flat. So here what happens is there is an eccentric contraction of the anterior groups of muscles. Eccentric contraction in the sense that there is an active lengthening of the muscle even while it is contracting. That is, there is a slow release of the length of the muscle. Otherwise, the foot will just drop onto the ground. So this is called an eccentric contraction, that when there is a lengthening of the muscle during an active contraction. So once the foot is flat and plantar flexed, the next event that takes place is the tibial rocker, where which the tibia moves forward on the fixed foot. Here you can see the plantar flex foot again becomes a dorsiflex foot. Mind you, these are all closed chain kinetics. Closed chain kinetics in meaning that the distal part is fixed and the proximal part is mobile. So these are called closed chain kinetics. So when there is a plantar flex foot, has now become a dorsiflex foot. Here there is an eccentric contraction of the posterior group of muscles. But the great toe comes into play in the third rocker period or the third period. Here, the great toe has to dorsiflex well to allow the foot to propel the body forward. This is called the metatarsophalangeal rocker. Here, the most important thing that has to occur is the dorsiflexion of the great toe. The dorsiflexion of the great toe here is not without reason. There is a particular reason why this has to take place, because a well dorsiflexed great toe causes a flexion of the first ray, preserving the arch of the foot. And this helps in weight bearing of the entire load on this small area or the head of the metatarsus. Otherwise, the whole foot will just collapse and fall down. So to preserve the arch, the dorsiflexion of the great toe is very important. And this occurs by a mechanism called the windlass mechanism. So here, as you see, the intrinsics of the foot are inserted in such a way, as I said, they insert into the sesamoids and then travel on to the base of the proximal phalanx. They are made in such a way that when you dorsiflex the great toe, the first ray will plantar flex. So this helps in the arch tightening and allowing the arch to bear weight, causing the foot into coming into what is called a close pack position. So this helps in bearing of the weight during the terminal phase of gait or the heel off phase. So how does stiffness of the first MTP joint cause problems? The stiffness can be divided into a passively rigid MTP joint, which is called hallux rigidus, or it can be a passive joint which becomes stiff on weight bearing. So this is called a functional hallux limitus, which occurs only when there is function going on. So as we said, this is the normal windlass mechanism. But if you see, the converse of the windlass mechanism is when you dorsiflex the first ray, the great toe will go into flexion. If you see the older picture, when we dorsiflex the great toe, the first ray will flex. On the converse, when you dorsiflex the first ray, the great toe will flex. So this, as just to recapitulate, this is because of the way the great toe muscles are inserted into the base of the proximal phalanx, the FHB, the adductor hallucis, and the abductor hallucis, and all of these muscles insert into the their respective sesamoids. And if you see, through a common intrinsic tendon, they will insert into the base of the proximal phalanx. So what happens when this great toe becomes stiff? So this is a normal great toe. So when there is a normal heel off, but when there is a stiff great toe, what happens is the patient cannot do a normal heel off. Instead, they will do a pronation of the foot and they will do a rotation of the foot itself. And so they will walk with a high amount of shear in the proximal phalanx head. So that is exactly where the entire load is going to go, and that causes a plantar hallux IP joint ulcer over here. And the answer to which is to do a Keller arthroplasty. That is to disrupt the entire normal anatomy about which we were talking so long. So once we are able to disrupt this windlass mechanism, the toe will immediately increase in mobility. The mobility of the toe will immediately increase. So once it increases, this will lead to reduction on head of the proximal arthroplasty. So this is the normal joint. What we do is we excise the base of the proximal phalanx. You can see the excised base of the proximal phalanx here. And this is how it is exactly done. So we go through a dorsal incision. An incision is placed in a more staggered manner. The skin incision is placed more medially and the tendon incision is placed more laterally. It is very important to achieve good hemostasis there. And then if you see, we don't go through the tendon, but we just cut adjacent to the extensor hallucis longus tendon and retract it aside, so that when you put staggered incisions, that is one incision on this side and one incision on this side, when you close it, they will again come together and like a curtain, they will close in layers. So even if the skin incision goes off, there will not be exposure of the joint. So the next step is to take out all the soft tissues on the base of the proximal phalanx, particularly the EHB, and then using a sagittal saw, what we do here is we cut about 20 to 30% of the proximal base of the proximal phalanx. So once that is cut, we use a good Alice retractor and then slowly divide the plantar intrinsic ligaments. So as you see, a stretch is put onto the tendon and the intrinsic ligament is cut and the bone is delivered outside. And what is left is a good gap over there. And this causes the toe to become more floppy. You can see that these are the cut plantar intrinsic ligaments. And now with you can see that even when the great toe, the first ray is dorsiflexed and loaded, the toe can even still move. It can move very well. It doesn't become stiff as it would normally. So if we dorsiflex the first ray, the toe is still able to move, and this will immediately reduce the pressure on the PPX head and lead to a good stable healing of the ulcer. So, and then the wound is closed primarily, allowing the tendon to slide to cover the joint. And the patient is kept in a non-weight bearing position for about 7 to 10 days and then slowly allowed to walk. Then once the wounds are healed, he is given a special footwear and allowed to go about. We have published a paper on this in the Foot and Ankle International, and in our series, we found that there was a 5% recurrence rate with an average of about 30 months. So this is the gold standard operation right now for a non-infected plantar hallux IP joint ulcer. So thank you for the presentation. Thank you for the time and the organizers. Thank you to Milendra sir for this opportunity. Thank you very much.
Dr. Madhu, an excellent presentation and video presentation, and this is what we require for the postgraduate students to know and to believe that this can be done, and surgical offloading can be done in patients, and they are very useful. So without wasting much time, the next speaker is going to be Dr. Amit Burande from Kolhapur. He is a MS orthopedic surgeon from Solapur, and now he's in DY Patil. He did his anatomy and as well as orthopedic surgery. Completed fellowship in diabetic foot surgery under Dr. David Armstrong. Completed ankle and foot fellowship under Dr. Rajiv Shah. And he's invited as speaker on state and national conferences. And he runs a hospital dedicated to diabetic foot in Kolhapur, Surya Limb Salvage Mission. Amit is going to talk on a very complicated diabetic foot entity called like Charcot foot, and I request him to be very specific about this surgery that he does and gives good result in skilled hands. Over to you, Amit.
Thank you, sir. Am I audible?
Yes, you are audible.
My screen is visible now.
Yes.
Directly, good evening, all in one. Thanks for the DFoot International officials and locator for the opportunity. I will directly start with the case capsule. 47-year-old man, type 2 DM on moderate control of HbA1c, neuropathic symptoms in 2 years. Deformity in both cases in 1 year. No history of rememberable gross trauma, acute swollen hot foot in last 1 year. Developed wound on medial side of the right foot, significant or intermittent serosanguinous discharge since 3 months back and stroke to bone positive in this patient. So this is a clinical presentation, a swollen foot, medial deformity, foot is in abduction. All lab is normal and HbA1c was 7.5. You can directly go to the X-rays, and what I want you to see in X-ray in the AP view is there is the collapse at the midfoot level and the deformity. So that the apex of deformity is on the medial side and the forefoot is laterally mobilized. You can focus here and you can see the osteolytic shadow in the bone. And as I already told, so probe to bone is positive, and the osteolytic shadow, they are more in fear of the local infection of the myelitis, osteomyelitis. So what is the possible diagnosis in this patient? It's a sarcofoot deformity, osteomyelitis. It's osteomyelitis, is it acute, subacute, chronic, refractive, or combination of both? So you don't need to tell what is osteomyelitis, so basically a bone infection. But what is the Charcot? Name after a French neurologist. Charcot is caused by a progressive denervation-induced degeneration of the foot and ankle joint, but not limited. I have seen patients having the knee Charcot as well. And the most important essential factor is the different kinds of the neuropathies, in which metabolic and hormonal is the most common one right now. And leprosy was there just before this diabetic epidemic has begun. And it should be contributed by a trivial or non-trivial trauma. And what it causes is the autonomic dysfunction, the local hyperdynamic circulation, washout of the bone, and resulting into the fractures and deformities. It goes through the stages. I will not go into detail because I want to explain you the case capsules. You can go this in the next. And so in the stage 1, it is just a swollen foot without radiological signs. In stage 2, or actually stage 1, stage 1, there is a bony fractures will start, the limb is still swollen. In the stage 2, the debris will be removed, and the stage 3, the remodeling and the deformities will come. Most important factor here is knowing the area of the sarco. So type 1 is in the midfoot, type 2 that is the hindfoot, and type 3A and type 3B are around the talus and the calcaneum. I'm fortunate as well as unfortunate enough to deal with all these locations of the Charcot and get opportunity to work on that. So let's come back to our case. This is the patient in the AP view. We are seeing the deformity. What we want to correct, to compare, I have taken a normal foot X-ray, not of the same patient, just for a comparison because opposite side is also involved. So now from this X-ray, what we have come to know is the degree of angle, that is between the talus and the first metatarsal has to be at 12 degree of varus, and what is actually in our patient is that's a 20 degree of valgus. So we have to correct osteotomy, correct 32 degree of varus total. But there is one more hitch, that we have to, the two axes, this is the actual deformity axis and this is the correction axis. You can appreciate that the axis is going almost 3 centimeters anterior to the actual center of deformity. So I have to take one more point equally posteriorly so as to plan the deformity correction. And when the crossing of axis is away from the apex of the deformity, there is always a translational component. These are little complex things you will learn as you progress further. So it was osteotomy planning on the paper. I went ahead, I cut, I approximated, and this is what I get. So I am reasonably happy at least on the paper, and now the main task to execute on the patient has come. So surgery started with the posteriorly tendo-Achilles lengthening. Then we went medially, the bumpectomy was done. And here we will see why it is important. This is a normal foot. It's a little diagrammatic by my hand. So it's a posterior column from talus to calcaneum, and anterior column, and the tendo-Achilles is acting. A is a normal. And what happens in Charcot is already it has gone from the ground that foot has gone a little bit in air, and actually when patient puts the pressure, it will go still upward. So the break will be in the midfoot somewhere, and it is because of the short tendo-Achilles. So surgery has to begin, any Charcot surgery has to begin with. So point number 1, take home message, every Charcot surgery will begin with the Endo-Achilles lengthening or cutting if you are going the peritalar fusion. Now, intraoperative planning again, that you cannot just do osteotomy on your own. I again confirmed with the 2K wires, confirmed that all essential bones are being cut, and I went ahead. After doing the osteotomy, what things I have done, this is I mobilized, hold the foot on the medial side, fix it with the beam. This is the principle of beaming. I use the K wire. I will tell you why. Because that was an infected foot. What you can see on lateral side is again a bone graft. Why this graft is kept? Because if this fails, the foot will again go laterally, but this will act as a wedge, like the stopper in your door. If this fuses, this will not allow the foot to collapse again laterally. On medial side, you can see a lot of antibiotic coated bone cement, that is the stimulant. And this is an additional, I can say, the precautionary measure I took, that the distraction. So medial column is compressed and the lateral column is distracted in a simple way. This is how, and in the lateral also, I could achieve a significant restoration of the arch. So this was the maybe second or third post-operative day. Post-operative protocol is very important. When the bone is involved, infection is there, IV antibiotics 3 weeks, oral antibiotics minimum for 3 more weeks, even if there are no symptoms. Delayed stitch removal, strictly non-weight bearing 5 to 6 months. My protocol is minimum 6 months. Good metabolic control, BCS lab or cast for the 5-6 months. There was little discharge that remained for 3 to 4 weeks on the medial side, but that stopped and the slab was continued. At 12 weeks post-op, fixator is out, and I'm happy that the bone is looking uniting. Here is also uniting. You can see only 2 simple K-wires are holding all these structures. No need of very fancy implants. If your surgical principles are correct, no need of very fancy implants. I'm going to talk about it afterwards. So at the 19 weeks, all grafts are consolidated, united, fixed, foot is rock stable. But I'm worried that his opposite limb may require a surgery and need to augment this structure, because I cannot keep it in future. It should not break. So for the augment at the 19 weeks, this was the clinical picture. So I went for the consolidation, which is called as the beam screws. I did the fixation. This is the most important joint. Whenever you are dealing with the Charcot, especially midfoot and hindfoot, my philosophy is your patient's foot should look like a hanger, something coming from vertical, one anterior limb and one posterior limb. And you can achieve it by fixing calcaneum into the talus, talus into the midfoot, and midfoot into the calcaneum. So once you make this triangle, nothing can break unless and until he goes into the major accident. Okay, but again, I am not satisfied till here. What is happening here is, after fixing all these things, there was a still little lateral instability. I cannot reconstruct. Ligament reconstruction is very difficult in this patient. So I chosen a little safer option. Peroneus brevis, I shortened and I fixed, so I got the laterally stable foot. No peroneus longus, because if you shorten the peroneus longus, there is a possibility of having an ulcer below the head of the first metatarsal. Dr. Madhu is the expert in that area. So this was the picture, and this is opposite side. Now the decision whether to go ahead. I'm showing you this case very purposefully. It is very easy for me to convince this patient to fix the opposite side deformity, as I have done good on one limb. So this was the X-rays of the opposite limb. It is definitely deformed, but if you see, as the osteolysis was there in the first opposite side on the right side, you don't have the aggressive osteolysis. These are the serial X-rays. There is no much difference, and arch is well maintained. And comparative, I have put 3 months apart X-rays. I will prefer to observe this patient right now. Now we will, in short, discuss the principles and prerequisites of the Charcot reconstruction. So first is preoperative planning, the location of deformity. Depending on the location of the deformity, your osteotomies will be planned and your implants will be decided. So most commonly, you see the areas in the type 1 and the type 2. In type 1, you will get either a medially deformed foot or a laterally deformed foot. And type 2, you typically get the talus has started migrating from its position and coming down. We have the patients will go through. Second is proper clinical evaluation. A good vascular status. What is the stage of the forefoot, midfoot, hindfoot? That is the most important point for me, is knowing the apex of deformity. If you know the effects of deformity, only then you can plan the osteotomies. And take my point, all osteotomies, they will be in a three-dimensional plane. There will be the rotational osteotomy. Then radiology is very important. I will tell you what X-rays are to be taken. These are the 6 X-rays. That is the foot AP, foot internal rotation, foot external rotation, ankle standing, the ankle AP, arc lateral, and calcaneum axial. In these 6 X-rays, you will have definitive plan of your surgery. MRI and CTs, they are just adding. Only if grossly infected limb is there, I need an MRI. Or if I am suspecting the talar avascular necrosis, whether to preserve the talus or not, then I will need it. Then IWGDF concern, especially I will just highlight this point, upfront cost of the implants and high postoperative medical complications. But from my experience, you will say that cost of the implants I have minimized. So you should know your implants. I will just go through the ring fixator, the plate, the K-wires, the screws. See, beam is a principle. Beam is not a screw. You can put a K-wire by beam principle. You can put a screw in a beam principle. So this is especially used for the hindfoot charcot. That is why I called it the CPT nail. And these are the ring fixators. Bone graft, you must be ready to take huge chunk of the bone graft, especially when the talar loss is there. Iliac crest, proximal end of tibia from either side, 4 sides you can take. And there can be a cortical graft, or preferably you should go for the cancellous strut graft and cancellous graft, which are just compressed and mortarized. So this is how I would like. This is the chunk graft I will do for the major structural defect, and surrounding is the small graft, that is alveolar. So it is a osteoconductive and this is osteoinductive kind of the grafts. These are the bone graft substitutes. Still reasonably economic when very huge voids are there and very osteoporotic bones. I use these grafts. The only principle is they cannot be put just alone. Little bit of intrinsic bone has to be put. And the best thing is whatever the operative blood has come out, I will keep it soaked for a couple of times. So the general principles of surgery. So here I will go. There's a TA lengthening, osteotomies and bumpectomies, the bone grafting, table fixation, implant of choice, post-operative protocol, and rehabilitation. So this is how I will just go through the slides as I have a very limited time. Talking on the charcot in that time is not very easy. So this is the most favorite slide, or this is the most explanatory slide for you to understand the osteotomy planning. And this is very small video to see how actually the bone is osteotomized and debrided. Very important thing is most of the chronic charcots at the stage at which we are operating, the sinusitis has reasonably solved. But as compared to the normal joint, there is a still synovial boginess. And what I am doing is removing exclusively all synovium. Whatever is the soft tissues remaining between the joints, we have to remove it. Just let me know about the time. Huh? So this is about, this is how actually you debridement, the Siam fixtures. Then you should put the temporary fixation, what you want, how the foot you want. This is to be fixed temporarily, and then at this stage we'll put the grafts, and then we'll go for the definitive principle. So it's absolutely a circadian or the rhythm-based surgery. There is no shortcut. You cannot just say, and whenever you feel this is insufficient, you add something. In routine orthopedics, we say what we need is a stable fixation and reasonable alignment. For a charcot foot, I want absolutely good alignment and a very rigid fixation, very rigid stability, and still I will protect it post-operatively with the absolute non-weight bearing. So there are some more cases. If time permits, I will just show you. Otherwise, we'll go to the discussion component. Okay, sir? You are muted, sir. Okay, sir, you are muted.
I think our time is a little less, so you can show one cases and then we can.
You want to see again this? I would like to tell about this patient. You can see on left side discharging wound 1.5 years. Foot is deformed, classical rocker bottom, but fortunately talus has not still started coming out. But you can exactly see where is the effects of the deformity. Wound is exactly there. It was a very long struggling case for me. I do the debridement, K-wires, Inzaro ring fixator, because I was suspecting, when I suspect active infection, I will not put internal implants, I will just put minimum stabilizing internal K-wires and a ring fixator. At the end, 7 months, the wound has healed and a reasonable arch has been maintained. This is a forefoot was not a big problem in this patient. And this is the worst side, the same patient on the opposite side having a discharging, just a presentation of a discharging wound, but this is sarco with osteomyelitis at the hind foot at the calcaneum, what we are seeing. Here we went with aggressive just debridement because there was nothing to do. I didn't touch tendon Achilles. I just do the all the infected bone excision. And at the end of 8 months, this lady was so happy to wear a normal shoes on bilateral side. Limited walk was allowed. She was encouraged to attend all the marriages and all family functions. So my aim of reconstruction of any sarco or any complicated diabetic foot patient should be back to normal with the normal shoes. At the most, I would like to give him some plantar insole modification. But though, if you want to give those bulky shoes and ankle foot orthosis, then we should not operate on this case. Our aim is walk with Reebok. The happiness is immense when they enjoy the family function in these typical feminine skin color shoes. And see, this is one more case, talus is coming the ground and we have fused the same patient on the opposite side, a beautiful reconstruction of the arch. Should I stop there?
Okay. Yes, Amit, I
If
think
there is any question, I will go ahead with the question.
because we have got questions and I've got one more lecture to complete in 5 minutes. Okay, so I think we'll start the next lecture, Jay.
Definitely.
Sure, sir.
Yeah. Can I share?
In the stop sharing, yeah, I have done stop
We are going to talk quickly before we start the discussion. Yeah. So there is a lot of talk about biofilm and the management. So to understand that, I'll quickly go through this small lecture of factors inhibiting wound repair. The most important factors that we see is the increased bioburden. And what we fail to detect is out of 4 in 5 chronic wounds, if you see the published data, have biofilms. Now, what are biofilms? Biofilms are polymicrobial infections where there's a core group of bacteria surrounded by planktonic bacteria, and they are covered by something called as a slimy barrier of sugars and glycocalyx. It's called as extracellular polymerase cover and water produced by themselves. And this barrier protects the microorganism from external threats like host defenses and antimicrobial therapy or local applications and even antibiotics. Now, why are they able to do? Because they live in colonies, they communicate through each other through water channels. They distribute water nutrients inside the colony in such a way that they live very securely. They pass the genetic information in such a way that they develop resistance to antibiotics and local preparations. If you do debridement of these patients, you will see that there is an immediate recurrence of the biofilm. When you see the microbiology picture, there will be mixed organisms, about 2 or 3 in, or sometimes 4 microorganisms in one tissue culture. So you have negative bacteria more common in this, like Escherichia coli, Pseudomonas, Klebsiella, Proteus, and less gram-positive bacteria in biofilm. So there are stages where within immediately after minutes of attachment of this kind of bacteria, they start forming biofilms and they mature in hours. And once these are released in the general circulation, you get a phenomena called SIRS. So when you debride this wound, they regenerate fast, and there has to be, and why this happens is because there is a prolonged period of inflammation. There is a upregulated immune mechanism getting operated where influx of neutrophils happens because of local level immune disorder. A prolonged inflammation occurs and increased levels of matrix metalloproteins 9 and 16, which accumulates and cause chronicity of the wound. Now, the diagnostic guideline to recognize biofilm presence is in the wound getting stalled. It is not healing well. So heavily exudating wound covered with fibrinous necrotic tissue requiring repeated debridement but recurs in 24 hours. Persistent wound infection despite the correct dose and duration of appropriate antimicrobial therapy. Microbiological evidence of localized infection with polymicrobial infection. So why are biofilms so difficult to manage? Chronic long-term infection resistant to host defenses, difficult to diagnose, frequently resistant to antibiotic therapy, and difficult to treat. Only cure may be removal and avoiding reformation. The principles of wound biofilm management is the gold standard of debridement, followed by an anti-biofilm strategy where you give dressings in such a way that they don't recur, and then you put something like a negative pressure wound therapy, reassess the healing. If it is recurring, you go back to your debridement and putting the anti-biofilm strategy. So this is what we have seen published data that only debridement is not going to work in biofilm. You have to have an anti-biofilm strategy. Now, what should you do after debridement? Whether it is scalpel debridement, ultrasonic debridement, or enzymatic debridement, is to put selective biocides. So there are certain things which are been used now: cadaxomer iodine, PHMB, silver, hydrophera blue, glutamate sorbate. There are certain things in pipeline like lactoferrin, xylitol, farnesol, surfactants, polexamer, which are anionic surfactants, and fatty acid gels. In India, the very cost-effective thing that I've been using is cadaxomer iodine, which is a time-tested iodine, but this is released not like povidone iodine, but in a sustained manner. Some cases where this is the patient with a large abscess in the toe with loss of soft tissue, we did an amputation, and this is how the application of cadaxomer iodine is done. But it is very tedious. It was very tedious. There were small beads, and you have to be very, very careful while applying. You cannot press, or the beads would break. Now they have come up with cadaxomer powder, and this has got 3 components in this. These are some of these. So this is how you got the red granulation tissue of the applying the cadaxomer iodine. These are some more cases with topical dressings and the wound turning red. Some patients, we have to combine it with negative pressure wound therapy. One more case where a classical biofilm, which was debrided, then cadaxomer iodine was used, improved granulation tissue in 21 days. So the 3 components of this is polexamer, which cleans and breaks biofilm. This is an anionic surfactant, so it is less toxic on the patient. Cadaxomer is a catalyst which has got a hygroscopic property which dehydrates the extracellular membrane and causes breakdown of the extracellular membrane of the biofilm, absorbs, exudate, and prevents biofilm reformation. Iodine is time tested. It is in the bead form, which is secreted for 72 hours, and that is how it becomes a broad spectrum antibacterial. It is found to decrease the Pseudomonas and even the Staphylococcus and MRSA organisms. In short, it is a desloughing, exudated, decreases exudate control, antimicrobial action, and provides a moist environment also for the wound to heal. Some studies, so these are the studies which were done in about 18 patients, small studies. We also have published that data from Kurababa Hospital, where we found that cadaxomer iodine resulted in microbial load reduction in 78% in one study. In the second study, about 64.7% patients showed significant reduction in mean microbial load post-treatment with cadaxomer iodine. When this cadaxomer was studied with different other ointments, they found superior action as compared to PHMB, which also has a good action, and hydrophera blue and other octinide. In summary, biofilm is a major concern for healing wounds. and in wounds are difficult to diagnose, treat, and frequently resistant to antibiotic treatment. Debridement alone would be insufficient to manage biofilms in wounds. Use of antibiofilm agents and selective biocides like cadaxomaridine and other agents that I mentioned showed promising results. Literature supports cadaxomaridine as most cost-effective in wounds complicated in biofilm in government hospitals and other hospitals where it would be a cost-effective management strategy. Thank you. And I think we'll go now to the question answers. For that, I would like Dr. Amit Nagate to join as a moderator and help me in asking questions. He's a consultant diabetic foot surgeon from Aurangabad, organizing secretary of DEFCON 2016 and organizing secretary of DFSI Midcom Pune. He's also a member of DFoot International. So I think, Amit, you can start asking questions to the panelists.
Thank you, sir. Thank you for your kind introduction. The first question goes to Regi, sir. What kind of post-operative antibiotic cares are the profile of antibiotic which you will use in DF?
Sorry, can you repeat the question? What antibiotic? Sorry.
Yeah, what antibiotic protocol are you going to use, or the choice of antibiotics for DF specifically, pre-operative and post-operative?
As we said at the routine, first of all, hi Amit, nice
Hello,
seeing you after a long time. Yeah.
Yes.
Yeah, for skin and soft tissue where gram-positive coverage is is important, I would prefer a combination of amoxicillin with clavulanic acid. Classically, that suffices for those. And as we said, in severe infection or in necrosis, where gram-negative infections are predominant, then a combination of clindamycin and piperacillin tazobactam is something which we are using as a protocol. In still severe infections and septicemia, then meropenem can be added. This is what we follow in our routine surgical practice over here.
Okay. So just like to extend the question, there is always a doubt that we need to take a deep tissue, we need to take a culture report. But what kind of culture sample are we specifically looking for, and we should send it across? This is what the general mistake done by most of the surgeons which are operating, or physicians which you were taking care of. So what kind of specimen would you like to suggest, and what is the need of it? Why is the need of that specific specimen?
It has been in the past that we were always sending pus for culture and sensitivity, but now the standard protocol is that one has to send tissue, especially infected tissue or slough, and it is best to send tissue from deeper structures. One, because on the surface there may be more of contaminants which are actually there but not actually causing infection or tissue destruction. It is only in the destroyed tissues that you can get some tissue which is slough, dead tissue, which you should send for examination.
Sure.
But
Thanks.
the standard protocol is to start broad spectrum antibiotics which are covering gram-positive as well as gram-negative, so that by the time you get your culture and sensitivity reports, the patient is not further landing in septicemia. But as we have been saying time and again, the most important thing here is that time is extremely important and source control is extremely important. So a good debridement, which I also said in my talk, is one of the most important takeaway message.
Very true, sir. Very true. My next question goes to Manisha ma'am. What are the contraindications of NPWT?
Hello, Dr. Amit. Thanks for the question. Thanks for the question.
Put on
And
video.
yeah, thanks for the question. And I have already mentioned that presence of in the one of the slides that the main contraindication is the presence of infection, ischemia, and the if there is lot of infection, ischemia. These are the main this thing. And we have also decided that it should be AB index should be between 0.9 and 1.3. TCPO2 more than 40. So these are the things, and any coagulation defect or any bleeding disorder which are pre-existing and PTINR is more than 2, then we should again think of not applying VAC. Any hidden pockets of infection which are present, then we avoid it, better avoid it. As for vascular or the ulcer, I've already told we should first go back and revascularize and then restart it, or or topical oxygen therapies may be tried to increase the oozing points, and then after that VAC may be applied. So these things we have to consider. Apart from that, if there is maceration or leakage, or leakage induced maceration, then also, or there is sometimes blister formation on the skin, then, or the patient is not tolerating the pain during dressing removal, then it may be unacceptable to the patient. It may not be tolerated by the patient, then it may not be allowed. Then certain patients may prefer it from the ambulatory or home things. Then that may also be a factor. So these things have to be, if there is any skin disorders or skin problems also, then also we cannot apply. Although protective skin films are available if there is something minor in the skin, but otherwise we mostly avoid in these patients where there is a lot of fungal infection, etc. We cannot apply it. Anything I missed?
That's only the vascular. If the vascularity is low, you should not use negative pressure wound therapy. We'll talk again after some time. I think Dr. Abhay Dalvi sir has put up his hand, and sir,
No, I'll come in last as a summary, please.
Okay. So I think the next question is to Madhu. What is a modified Keller's osteotomy, and is Keller's osteotomy the best procedure for plantar ulcer? You do it in the first go, or you wait for some other procedures before you advise Keller's osteotomy, because patients would not accept immediately. In our practice, we have noticed.
Sir, from our experience, the primary operation that is offered is scalar arthroplasty, because mostly the patients who come to us as a tertiary center, they've been through multiple options. They've already worn so much of footwear. They've tried everything they can. And then since we are, there is a bias in that. There is a bias in that. But if you see, as of today, the government of Tamil Nadu has taken up surgical offloading very seriously, and all government hospitals are the general surgeons from government hospitals are being deputed to the nodal center, which is Tanjavur Medical College, and surgical offloading is being taught to them, and it is being taken up in the government hospitals itself. So there is a lot of awareness that is being created, at least in Tamil Nadu, and people even in the villages through the public health system. So when the public health system is involved in that, the people are really convinced and they are ready for the operation. So as a protocol, we offer the procedure that has the best cure rates with the least recurrence rates, which is the Keller gap arthroplasty for plantar hallux IP joint ulcer. And we would recommend it as the primary procedure to be offered to the rural patient who particularly are not very good at sticking to wearing the footwear regularly and following strict instructions regarding other conservative offloading methods. And if you see the IWGDF guidelines also, right now the gold standard that is being advised for any plantar non-infected wound is a total contact cast. In fact, the guidelines advise that we should not prescribe footwear for active plantar ulcerations, particularly those of the forefoot, midfoot, and hindfoot. So when all of these, and when the total contact cast fails and other conservative methods fail, the final option that the guidelines submits to is surgery. So at least we think that primary surgery is good for our patients. And coming to the second part of your question, which is what is modified Keller's arthroplasty? Modified Keller's arthroplasty is nothing but it is an interposition gap arthroplasty. That is when a gap arthroplasty is where you create an artificial gap between the bones, but there is a chance that this can reunite, particularly since one of the raw areas of the bone is present, and there can be an amount of fibrosis over there. So to reduce the amount of recurrence, it can be either a natural inert material like a tendon or capsule of the joint or whatever. You can put it in between the raw bone surfaces. But usually in Keller gap arthroplasty, because one surface of the metatarsal head has the cartilage intact, bony union is very, very rare. So that is why I said there is only a 5% recurrence rate. So, and studies have been there which have compared um, simple gap arthroplasty and interposition arthroplasty. It has been found that there is no advantage in doing an interposition gap arthroplasty.
Do you
So
offload?
modified Keller does not offer any advantage over the original Keller.
Do you offload your patients after Keller's osteotomy?
Yes, sir. All patients are offloaded because when you do a Keller, you disrupt the windlass mechanism that will increase the load on the remnant metatarsals, particularly the second metatarsal head. So there is an increased chance of a transfer ulcer in the other metatarsal heads. So we would advise everybody, once the foot is in remission, we do advise everybody to wear uh, either custom footwear or at least ready-made prescription footwear.
How many days?
So all patients are offered the option of footwear, but unfortunately the compliance is very low.
How many days, Madhu, you should offload?
Offload in the sense strict non-weight bearing, at least till suture removal, sir. Because our patients, if you tell them to walk, they are not as careful as the Western patients are. They end up walking barefoot and causing gaping of the wound. And that is one of the reasons we use staggered incisions, medial and lateral incisions. We prefer to keep them non-weight bearing for at least 14 days.
Thank you. Dr. Amit, do we have to take a consent for failure of internal fixation in Charcot foot with so much of instrumentation in the foot? Do you think medico-legally we have to take a consent for failure of union? Yeah, please go ahead.
Not only in Charcot, but every orthopedic surgery, you have to take absolutely informed consent that there is a possibilities of post-operative infection, perioperative infection, implant failures, broken implant, malunion, delayed and non-union, and possibility of recurrent surgery and secondary bone grafting. And I take this consent very religiously, very meticulously for each and every patient I operate, let it be a radius ulnar nailing or it is a pollex fracture, in patient's own handwriting. So every patient is aware of what things are possible. It is not to make them scared, but it's a right of patient to know them. It's our duty to make them aware that all these surgeries are not like just a simple go surgery. But my experience is Charcot patients are ready to write whatever you want them to write, whatever you inform them, because most of them, they come to me like, everybody has suggested amputation, can you save it? But failure, fortunately, I haven't still faced failure only because I do a good, absolutely non-weight bearing offloading minimum for 5 to 6 months. And I choose the time of surgery very carefully. The recent guidelines or thought process, especially in Europe, are going whether you should start operating on the stage 0 or stage 1. And the papers are published, but is on the discussion mode. I operate only on late stage 2 and early stage 3 patients. Grossly infected foot, I phase out the surgery. In phase 1, I do only infection control. And phase 2, I try to use the both.
Thank you. Amit Nagade, any more questions? 2-3 more questions before we close?
Yeah. There is one question, Burande. How do you differentiate between an infected foot and a Charcot foot? Usually it happens because the Charcot presents with a red hot foot and it is infected, not infected. The bones are distorted. If it is osteomyelitic, non-osteomyelitic, so how you plan to differentiate between those?
The history is very important, that how all it started. Like tomorrow, I will be operating on one patient. Patient was presented to me as a Charcot foot. But when I took a very deep history, it's something like patient had 2.5 years old trauma, significant trauma, not the trivial trauma. Patient is a diabetic patient. Patient was offered a surgery, refused surgery, that went into some deformity. He walked on the deformity. And now when I see the X-ray, there is all the talotibial distortion is there. but foot is absolutely normal. Everything below the talus, everything is normal. So that is just a neglected non-union of ankle fracture. In a similar way, a typical midfoot deformity or a typical plantar ulcer, the talus is coming down or the midfoot is broken. That is 99% Charcot unless shown otherwise. But as you are rightly said, there is always a possibility that if you give me a permission, I have kept that slide reserved. If you give me permission, 1 minute, I will show you. It will clear all the doubts and all the things. Just let me have this slide. Can you see the slides?
Yeah.
This was the patient. The patient was, I was involved in this surgery. I was called to operate outside Kolhapur, typical swelling, diabetic patient, significant neuropathy. This is the X-ray picture. And in this kind of picture, I have operated 3 this kind of patients, and this can be a subtalar Charcot or this can be a pure infection, but I would not take risk. So just see what happens when I approach this patient. Yes. The pus, it's a frank pus which is just pouring out. So there is no question of doing any definitive procedure. We just went inside, very good debridement, no bone graft in such a badly debriding wound. You can appreciate the stimulant with antibiotics and just a fixator. And this is the result at the end of 5 months. I was very patient in this patient. What has happened is now, because of infective arthritis, talus and calcaneum has fused, but the talotibial joint is reasonably preserved and the foot architecture is reasonably preserved. I would not like to hurry and operate in this patient. So as I have initially only told that infection and Charcot infection, because osteomyelitis can cause a broken limb mimicking a Charcot, and Charcot can got secondary infected and mimic osteomyelitis. So these are absolutely borderline patients, and Eisenhower's classification doesn't include this. I am trying to compile the data and I will get significant number of patients. With evidence, I would like to show this data.
Thank you. Amit, any more questions, or we can ask Dr. Abhay?
There are a couple of questions actually. One is, what is the prospect of Woundsights or debridement? Interesting question. Anybody can take over it.
I think Tushar, you can answer if you're using Woundsights.
No, I have not used Woundsights. I have not used Woundsights.
So Woundsights is a debriding modality where you try to do a safe debridement without harming the tissue. So it is just if you have a good commercial, want to have a good commercial impact on the patient, because you can as well do a good surgical debridement. I have never wanted Woundsights, but it is as you know, the wound market is commercially driven and pharma driven. So if you are working in a plus hospital and you want to impress the patient, very rarely Woundsights would be required to the patient.
Okay.
But it's a good modality. If you
it's a good modality actually.
High, very costly.
Yes. There is one question, interesting one. Where do you put ortholytic debridement on a scale of 1 to 10? Tushar sir, can you take it?
Can
you repeat again? On a group of on a scale of 1 to 10, where would you put?
Scale of 1, where you put an ortholytic debridement agent on scale of 1 to 10. The person has not mentioned ortholytic debridement agent. Could you guide on the ortholytic debridement agent and where you can put it from 1 to 10 scale?
In a small wound.
Can I answer that?
Yeah.
Okay.
Yeah. If there are grossly intact anatomical structures that are sloughed out, that is, if there are dead, grossly intact anatomical structures such as a large tibialis anterior tendon, the extensor tendons, or a large eschar of skin and soft tissue, then autolytic debridement has no. Sharp mechanical debridement is better. It is cheaper, it is faster, and it gives better results. But in case where in areas where you're not able to, like a biofilm or something is there, and there is superficial surface slough is there, a large area of where it is, you cannot delineate the anatomical structure and have a clear, you cannot give a good clearance. There is a surface slough. For example, a below knee amputation is done and the surface of the muscle and the fat is still a bit ischemic and sloughed out. In such areas, autolytic debridement is better. So where you can't do mechanical debridement, an autolytic debridement is better.
May I add something?
But in yeah.
Okay, sorry, you continue. I'll talk.
No, it's done, please.
Okay, and I have found it working very well, especially in the connective tissue disorder, the vasculitis wounds, because you might be remembering we had discussed that abdominal patient post-cesarean, a very big necrotic scar was there, and every time the surgeon would do a mechanical debridement, the area will increase, the vasculitis will take more rampant, and it will become more flat. And so we just started autolytic debridement. Within 4 to 5 days, we got reasonably good slough out. And that patient was turned out to be the antiphospholipid positive syndrome. Similarly, I have got 2 patients with the ANA. You debride, you cut it, and ulcer depth will increase, ulcer appearance will increase. It will start getting more fluffy and pouring pus. But you be gentle with it. Just keep on gentle dressing with other immunocare modalities and the basic care modalities. They will be there. This is one more area.
Please, I think as the audience in general should remember that these are exceptions. These shouldn't become the norm. Because there is nothing like a surgeon's knife that can clean a wound.
I specifically tell you, because in
No. Just to get the message. I perfectly I agree with Amit.
Yeah, I think there is one just last question. Just sum up. There is one question named as protocol for local management. It's a vague term, but could anybody take it and just sum up in short? What would be a protocol for local management? It could be a wound management, I think so.
Yeah, okay. But wound management. Okay, for example, let's take it as wound dressings, as I always say. Wound dressings. Wound management, local wound management, or wound dressings. See, wound dressings you can just divide into 3 separate procedures: cleaning of the wound, topical application, and cover. If you break it down, it's very simple. So, cleaning of the wound is usually best done by a detergent and mechanical cleaning with water. That is what we think. So some people may prefer to use any. There are multiple other agents for cleaning of the wound, PHMB and things like that. But we prefer soap and water, just plain soap and water. If the patient is very afraid, you can use normal saline. So cleaning of the wound, mechanical cleaning of the wound is best. So that will dilute the biofilm. It will disrupt the biofilm. It will take off the slough. What loose slough is there, it will take it off. Then topical application. Topical application depends on the requirement of the wound. If it is an ischemic dry wound, you need a hydrating agent like an hydrogel. If it is an infected wound, you would require an antiseptic like silver and copper and whatever agent you want to apply on it, particular to the, if it is Pseudomonas, you can put acetic acid or whatever you want to put. If it is a clean wound and with a granulating bed, you want it to epithelialize, you can apply platelet-derived growth factors. So it all depends on the need of the wound. And cover depends on the discharge of the wound. If it is a low exudating wound, you need to apply some cover which has a low absorptive capacity, which are cheaper. If it is a moderately exudating wound, an appropriate cover. And if it is a high exudating wound, you need to apply either a alginate or a foam. Very simple. So if you just take it as cleaning, topical application, and cover, you break it down like that, then it becomes very easy as to what to apply in which situation. That's it, sir. So that is how we take our protocol of local management of the wound.
Very nicely put, Madhu. I think we have overshoot our time, 15 minutes, and I'm very thankful to the observer, our Dr. Abhay Dalvi, sir, who is still there with us. And sir, any comments from you, sir?
Yeah, I don't know most of you all, but I can only say that since I passed my MS and continued on the staff of St. J.S. Medical College and KM Hospital, for 40 years, 36 as a staff member. I've treated a lot of diabetic foot patients and I was always frustrated in treating them. I'm so happy that there are dedicated people who are looking at diabetic foot as a specialty, and I congratulate them because it's an extremely complex problem. To me, diabetic foot has multiple problems which involves a surgeon, maybe a vascular surgeon, in the sense the entire diabetic foot is surrounded by surgeon, peripheral vascular disease, neuropathy, osteopathy, etc., etc., and is an extremely evolving system. And each one of you all are doing an excellent job in your own field. I think all of you all should come together. I know the associations have come together, but some sort of a algorithm has to come into system where everybody follows a particular path and involves a particular specialist as and when time comes. Now, just a general question, anybody can take it, that patient comes to you with diabetic foot. How do you know the role of vascular disease, neurological disease, and osteal disease? Osteal disease I can understand, for me, X-ray and osteomyelitis will be told. But I have learnt of so many things like osteotomy, etc., role of an orthopedic surgeon in treating diabetic foot. Ruke, I will request the pharmaceutical company to let the PGs who are attending know how does whose role and when it comes in, and how do you identify a person and how do you change a treatment when you know vascular component is important and neurogenic is important.
So to answer your question, sir, as a default, all diabetic patients, whether type 1 or type 2, has some element of neuropathy. So detection of neuropathy is very simple. There are things like, measuring the hot and cold perception, which is the first sign of losing.
No, that all PGs have already seen the person talking about it.
Yeah, once we do that, once we know that there is neuropathy, we feel the pulses of the dorsalis pedis and posterior tibial. We see for capillary refilling. We do an ABI index. If the ABI index is between 0.9 or 1.2, or if the TBI is toe brachial index is low, that means the patient has a vascular issue. Before that, the history taking, if the patient gives you history of intermittent claudication.
No, that is all done, Milind. My question was, in the study that was done both by the international speakers as well as the national experience, in their experience, how do they change the treatment basis of vascular disease is more, neurological is more, and how does the treatment change? That's what I was, because otherwise everything has been good. One more question I want to ask you is, as a person who has taught for a long time, there is a concept of angiosomes as far as peripheral vascular disease are concerned. And as I have understood what are angiosomes, grade 2 has the best of the blood supply. So does your diabetic treatment change because most of the images that I saw where grade 2 was gangrenous, and grade 2 is the last one to go in isolated peripheral vascular disease. So what is different here in diabetic foot?
May I talk, sir?
Yeah, please.
Yeah, Amit, please. Yeah, Amit, after you. Yeah.
I would like to always tell all PG students, focus on history and the way it all has started. History, and history. Whether there is a history of extrinsic trauma, intrinsic trauma, significant trauma, de novo, and duration. And when patient comes in your OPD, the location of the wound is going to tell what is happening there. Like tip of the great toe or any toe, there's a clawing, so neuropathy. As Madhu has shown, that area, typical neuropathy, coming little back, the head of the first metatarsal ulcer, that is again a neuropathic. Anything on the plantar side happening slowly, happening de novo, is a significant neuropathy. Anything happening at the tip of the toes and little bit of infective or very small trauma history, they are more or less a neuroischemic. The patients who are having all of a sudden a dry kind of a gangrene or development of the huge abscesses, they are more likely to be vascular deformities and instabilities. They are more in favor of the Charcot. The long standing, any wound that is not healing and you are having a deformity, it has to have osteomyelitis component below that. And when this all diagnosis is when just the patient has walked in your OPD and he sit and you are talking with him. Once actually you touch with him, whatever the classical investigations are to be done, like doing a monofilament test or the vibratiometer or doing a plantar fascia study, this all has to happen in the OPD of a diabetologist. When patient has come to a diabetic foot surgeon's OPD with the wound, he has already missed that birth and we don't need a monofilament to document there is a neuropathy. Ulcer itself is documenting there is a neuropathy. And when you are actually touching the patient, it is a strong recommendation that for every patient you do minimum arterial Doppler. It will be a very objective. It will be medico-legally very important. Then you take your patient for surgery. When in surgery and after surgery you find gross ischemia. I am not talking about only 1% of those patients who have come as a black toe or a black foot, which are classical vascular cases. Most of the patients, you will see that Doppler report is showing the tandem areas of the fast calcification, and few vessels are showing monophasic, who are showing the resistance kind of the flow. You start operating on that patient. If your post-operative view shows the wound is not doing well, then again involve the vascular person, but 90% of the times you don't need to do any vascular intervention. Because a vascular intervention in non-required situation, it will aggravate the vascular occlusion. This is how take my patients. Very practical approach. You don't need to have any classical guidelines, classification or something like that. The wound is telling that what is the problem.
Good, Amit. The basic thing I just wanted to come to for the benefit of the PGs is that as far as my knowledge of vascular anatomy is concerned, grade 2 should go last. So if grade 2 is the first presentation, one should consider not only vascular disease, but also neurogenic disease, which are combined together to give this type of presentation. That's what I wanted the PGs to know.
90%
It can also be because of infective embolus.
Yes.
Okay, you are the best people. I always, if a diabetic foot comes to me, Tushar will smile. I just send it to him.
No,
and he saved a lot of my patients. So
what I am trying to say here is 90% of the grade toes which I have amputated, they are a classical neuroischemic. Because of the neuropathy, there is a subtle trauma. Because of the ischemia, wound is not healing. Infection is taking place, that is causing local embolus and vasculitis, and you lose the grade. Very rarely you see the grade toe being loose for the pure vascular reason.
I think Dr. Manisha wants to say something.
Yeah, yes, sir. Good evening, sir. Sir, I just wanted to say, even if you feel that you have good bleeding at the debridement site, and its palpable pulses are there, still it does not rule out a ischemic component or a proximal block because of the segmental pattern of blockage in the diabetic. So you have to do a color Doppler assessment if the AB index is deranged. And so hence, even though they say that ABI is less commonly performed now, I am doing it as a routine. And if the ABI is showing it is less than 0.7, I definitely go for a Doppler. And it is even segmental measurement of blood pressure are done in the focused vascular clinics, which I am not doing. But a good assessment with a Doppler is essential if the ABI is deranged, and hence the patient must follow a particular protocol of assessment of neuropathy with the biotensiometer and with the vascular assessment, and then go for surgeries. So neural and vascular assessment is an essential part, along with the pressure studies, which are essential.
Madam, how good is Doppler to know what is the flow through the medial plantar artery, lateral plantar artery, peroneal artery?
Sir, even
if I can,
yeah, Madhu, please.
If I can answer these questions, yes, sir. Yes, sir.
Sir,
to answer your, madam, just yeah, can I answer that?
Fine. Go ahead.
Yeah, no problem. To answer your question first, which Amit had answered, because I told that I would also take my turn on that. The protocol, with all due respect, all of the protocols that we are currently following as surgeons have been narrated by the physicians. Yeah, what we are following is a physician narrative right now, and they are starting to see the surgeon side of it, because we think that all of the um, feet are ischemic feet. No, it is 85% of, as Amit said, 85% of our diabetic foot problems don't need any vascular intervention. To decide whether it is a vascular problem or not, we use a clinical examination. If there are no pulses, we would do a Doppler. But and if the Doppler shows ischemia, we would do an MR angio, and then call the vascular surgeon in for an intervention. Otherwise, if we feel that there are palpable pulses, then we usually go ahead directly. As plastic surgeons, we go ahead directly and start treating the patient. If required for medical legal purposes, you could take a Doppler to document that the vascularity was good, so that if there is a problem later, you always have a defense on your side.
Sir, the
So
most important thing that I want to come in, Madhu, sorry to interrupt you.
Yes,
is
no problem.
your pulses are normal, your Doppler anterior ABI index is normal. There are very rare cases, which sir was saying about the gangrene of the toe, where you find the capillary. It's a very simple test. Capillary refilling is not happening. So there is a distal obstruction of the dorsalis pedis or the arch, which can occur in some patients. And even if your proximal pulses are okay, distally you may get a block and you may get a gangrene. So that you have to be very careful by doing something like toe brachial index or capillary refilling test, which is 3 to 5 seconds it should refill. That's a very good test for government hospital PGs to know the terminal pulse circulation, how it is, a clinical test.
And,
So don't you think, Milind,
Yes.
I'm wise enough to refer patients of diabetic foot now that I'm in private practice to diabetic specialist?
Yes, sir. You have not referred me, sir.
Yes.
Now you and Tushar should not fight. I am observer for medical council. Anyway, congratulations to each and every, not only international, but I think the national speakers were very good. I have learnt a lot despite of being away, and rest assured, I will still keep on referring patients to diabetic foot surgeons. Thank you so much, Milind, for calling me as an observer, and everybody should get credit point, just see to it. And all the speakers, thank you so much.
Thank you.
Thank you, sir, for being through the whole proceedings. I think it is difficult to be through the whole thing, especially when you're doing a lot of other work also related to the abdomen and other things. Thank you so much.
So I take this opportunity to thank Dr. Abhay Dalvi, to thank all the national and international speakers and the moderator and the JB Pharma, who have done a wonderful job and given this platform to connect with the postgraduate students. And I thank all the postgraduate students and delegates who are still with us. And I now tell Dr. JB Pharma's Jai Savai to give the Thanksgiving and end the program on a good note.
Thank you so much, Dr. Milind Ruke sir and Dr. Amit Nagate sir, for wonderfully moderating the entire panel discussion at the end. And also would like to thank all the expert panelists, Dr. Tushar Rege sir, Dr. Manisha ma'am, Dr. Madhu sir, and Dr. Amit Burande sir, for making the entire panel discussion so very interesting at the end and taking up all the questions wonderfully. So with this, we are coming to the end of our scientific program, Catch Them Young project, an educational initiative by DFoot International in association with Association of Surgeons of India and Mumbai Surgical Society. We, on behalf of JB Pharmaceuticals Limited, are extremely thankful to all the expert doctors, both national as well as international doctors, and the association for this scientific collaboration as an academic partner. We would also like to extend our vote of thanks to Maharashtra Medical Council for providing the accreditation to this scientific program. Thank you so much, everyone, and I'm sure all the sessions would have enlightened all of you and would help you in enhancing your knowledge in wound care. And with this, at the end, would like to thank our respected program director, Dr. Milind Durke sir, for beautifully devising the entire agenda and nicely curating all the topics in the field of wound care. At the end, would like to thank all the viewers and the postgraduate students specifically for participating in this grand conclave Woundsights, and would also like to thank all the head of department of All India Medical College for supporting this collaboration to allow us to take this education event virtually in your esteemed premises. With this, we conclude for today. Thank you so much, everyone. Stay safe, take care, and we would certainly connect in near future with such similar scientific engagements. Thank you so much.